Okay, so Bismillah ar-Rahman ar-Rahim. We're going to start another exciting day today. Yesterday was very successful one. I'm very happy. Everything went smooth. We have a lot of great feedback from yesterday, and we are looking for another exciting day. And today the schedule is really very rich. The program is really rich. We have all very unique and speakers and very interesting topics. And for this session, for general cardiology session, we're going to start with Dr. Joseph Rogers from USA, and he's going to talk about acute heart failure and cardiogenic shock and answer a question and a path forward. Then we can have Dr. Leslie Miller to talk about catheter-based management of acute and chronic heart failure, practical changes. Then we have Dr. Annie Verghese. She's going to talk about, she's the only one going to do, I guess, live presentation on ECP in 2022. And probably that will add something for heart failure management. I don't know what we're going to hear from you.
Yes.
And then with Dr. Galal Kailani, he is going to talk about the paradoxical low flow aortic stenosis, diagnosis, imaging, and intervention. And the last we'll have Dr. Yasser Minansi. He's going to talk about MI complicated with VSD. So we are all excited about this session, and we're going to have a discussion. Hopefully we'll have enough time for discussion toward the end.
Awesome. Let's do it.
Hi, I'm Joe Rogers. I'm the president and CEO of the Texas Heart Institute, and I'd like to thank the organizers of this conference for the kind opportunity to speak to you today about acute heart failure and cardiogenic shock and explore some of the unanswered questions and think about a path forward. I have no disclosures related to this talk. I'd like to just start with the definition of cardiogenic shock. This is from the European Society of Cardiology, published a few years ago. I think it's applicable today. It hasn't changed that much, but I think it's important for us to have a definition so that we can begin thinking about the clinical syndrome and how we can advance knowledge. So shock can be defined as persistent hypotension for more than 30 minutes with vasopressors to achieve a blood pressure of greater than 90, or persistent hypotension without vasopressor support for that length of time, associated with some evidence of elevated left-sided filling pressures, and signs or symptoms of impaired organ perfusion, which might include changes in mentation, cold and clammy skin, a decreased urine output, or an elevated serum lactate. And I think that Sky has done a really nice job in helping us categorize the various stages of cardiogenic shock. And this aligns with some of the other initiatives that we've come up with in the American College of Cardiology and the American Heart Association, where we're trying to simplify a conceptual framework for complex diseases. So this A to E kind of concept that I know you're all very aware of, where stage A are individuals who have had some event and places them at risk for cardiogenic shock, all the way up to the stage E cardiogenic shock, which is for people who are in extremis, who have had circulatory collapse, are getting cardiopulmonary resuscitation, etc. So I think that this is an important advance for us as we think about how to categorize our patient population in cardiogenic shock. And again, will help us as we begin to think about how to develop a body of knowledge to advance the science of acute heart failure and cardiogenic shock. This was a nice paper that was published a couple of years ago in Circ Cardiovascular and Quality Outcomes that looked at a contemporaneous group of patients who were in our cardiac ICUs with a diagnosis of shock. And on the left side of the slide, I think you can appreciate, it's about 2/3 of the patients in a contemporary cardiac ICU have cardiogenic shock, but there's a mixture of all other kinds of shock in there. And when you look at the causes of cardiogenic shock, you can see that about 1/3 of them are related to acute myocardial infarction. The other 2/3 are related to non-acute myocardial infarction causes, including a large group of patients who have non-ischemic cardiomyopathies. And so a lot of our trials in cardiogenic shock have really focused on acute myocardial infarction as the driving etiology of shock. And it's an easy event to capture for a clinical trial, but it's excluding a large number of patients who are in our intensive care units who have a cardiogenic shock. And regardless of the etiology of the shock, it's pretty clear that the outcomes are poor. This was an analysis from that same paper that demonstrated that the in-hospital mortality for cardiogenic shock ranges between about 30 and 40%. And the vast majority of that mortality is occurring in the intensive care unit. So we have a lot of opportunity to improve our approaches to these individuals, to identify them earlier, to intervene earlier, and to develop strategies that have demonstrated improvements in outcomes for our patients. And I think this will be a key highlight as we think about what our opportunities are. This is just one example of a variety of algorithms that help the practitioner walk through how to manage this patient population. And it starts off with first identifying the patient population. And again, in this particular example, it's individuals who've had a myocardial infarction. But again, that's only about 1/3 of the patients who are in our intensive care units. But thinking about the right kinds of diagnostic tests, and then the right kinds of support strategies for that patient population, including intra-aortic balloon pump, some of the other temporary mechanical circulatory support devices that we'll talk about in just a moment, with another assessment at that point to see how you're doing, and always begin thinking about what's the long-term play for the patient. What is the exit strategy for this patient who has cardiogenic shock? And that should always be one of our thought processes early on as we gather different practitioners around a patient who has cardiogenic shock. This is a very simplified schematic for a sophisticated audience like those attending this conference, but here are just a series of different temporary support approaches that we have available to us. The oldest device, of course, on the left, the intra-aortic balloon pump, the family of devices, the Impella devices that have matured over time and gone from relatively limited amounts of support for hemodynamics to much better support, and to the point actually that the entire circulation could be supported with these devices with the larger pumps. There's been a growing interest in the use of ECMO as a support strategy in the very short term for the patient population. And then a couple of other devices like the tandem heart and the IVAC, which also have been demonstrated, at least in small patient cohorts, to provide some advantages. But as most people on this at this conference know, we don't have much in the way of compelling long-term outcome data to support the use of any of these strategies relative to standard therapies. So I guess I would close with a couple of thoughts for you in the next few slides. And first, as we're thinking about cardiogenic shock and acute heart failure, what's working well? And I would say that today, clinicians have a variety of different devices and drugs from which to choose. cardiac care units and the teams in them have evolved from managing acute ischemic heart disease to really a more holistic approach to caring for critically ill patients in shock. It's not all just about supporting the heart. We've really developed a deep appreciation for the fact that this is a multi-system disease. And if you're not addressing all of the issues, then you're unlikely to have an optimal outcome. There's a growing interest in the idea of using heart teams where you bring together very quickly large groups of talented, thoughtful specialists who can support the patients in different ways with their various expertise. And I would say that we have developed a series of good longer-term strategies, exit strategies, if you will, for the patients with cardiogenic shock and acute heart failure that include the longer-term mechanical circulatory support devices, advanced surgical therapies, and transplantation. But I do think that there are some practice and knowledge gaps that we need to begin to close. And I'll just would like this group to think a little bit about some of these questions. Is the pathobiology of all cardiogenic shock the same? You know, our understanding is really a hemodynamic understanding. But I think that there are probably differences that we don't appreciate between acute ischemic heart disease and decompensated chronic heart failure. And that may actually tailor our approach to the management of this patient population. Do practitioners recognize cardiogenic shock? Yes, I think in the setting of an acute event like an acute myocardial infarction, it's easy to recognize cardiogenic shock. Much more difficult in the patient with chronic decompensated heart failure that's decompensated over weeks or months, and they come in with the same signs and symptoms. It's less obvious in many cases because we've watched the disease evolve over time. I think that communities haven't organized in a very efficient manner to manage cardiogenic shock, honestly. You know, this idea of developing hub and spoke kind of approaches where smaller hospitals that don't have a heart team and don't have all of the resources should be thinking about partnering with larger centers to move those patients to optimize the chances that they'll have a good outcome. And I think we've recognized that there's a group of patients that has ambulatory cardiogenic shock. They've walked around in cardiogenic shock for years and they've been okay, at least if you use hemodynamic criteria. What's different about that population? I think we have something to learn from them. And finally, I think that the role for drugs with positive inotropic properties is rather unclear at this point, but it really is untested in a patient population who has shock. If you go back to many of those trials, we were studying patients who were not in cardiogenic shock. They had either acute decompensated heart failure who had come in because they were volume overloaded or had NYHA functional class 3 heart failure. It would be interesting to redo some of those studies in a patient population who had documented shock. And finally, I think that there's probably some ways that we can match the patient to the intervention more carefully. And we should be thinking about the severity of ventricular dysfunction. We should be thinking about whether the right ventricle is involved. And there's probably a complex interplay of comorbidities that today we don't understand. And finally, and particularly in the United States, but I'm sure this is an issue worldwide, is that the changing healthcare environment disincentivizes many hospitals from trying to understand and manage complex, expensive care. And I think that we need to find this balance between evidence-based approaches and developing that evidence base. We need to continue to be innovative and thoughtful in this space as we develop new strategies and we develop a knowledge base around the management of acute heart failure and cardiogenic shock. So again, I'll thank the organizers of the conference for the kind invitation to speak to you today. I wish you the very best for the rest of the meeting. Thank you very much.
Hello, this is Dr. Leslie Miller. I'm very pleased to be included as a part of the faculty in this excellent meeting discussing many of the issues in cardiovascular medicine today. My presentation today will be somewhat groundbreaking in that it discusses the catheter-based management of acute advanced heart failure, which represents a true paradigm shift. These are my disclosures. There have been a number of catheter-based approaches to the management of particularly acute decompensated heart failure, the first of which shown here, the intra-aortic balloon pump, which has been around for 40 years, but for which there's been very modest documentation that it actually can improve long-term outcomes in patients with advanced heart failure. More of a salutary type mechanism is referred to as extracorporeal membrane oxygenator, or the ECMO circuit. It's designed really for resuscitation in patients with acute severe cardiogenic shock. It removes all the preload from the right atrium, returns it retrograde through the femoral artery, or a veno-venous, if you will, return through the veins. It has an added benefit of being able to oxygenate the blood, requires full heparinization, and is being used increasingly today, but has no long-term data. The third device in the evolution has been the tandem heart. It was used for a brief period of time, again, this time using a catheter passed across the intratracheal septum to directly remove left atrial blood and then return it retrograde. Similarly, it has been used almost entirely for shock and is not currently in significant clinical use. The field really changed with the development of the Impella microaxial continuous flow LVAD. This percutaneously placed 22 French catheter can be inserted through the femoral artery and pass retrograde actually across the aortic valve, such that the inflow of the device is in the left ventricle and the return is just above the orifice of the coronary arteries and the ascending aorta. This pump can generate up to 4.5 to 5 liters of cardiac output, and initially it was used exclusively for acute shock, but is being expanded in its application to more extended support, such as pre-transplant. Unfortunately, it has to operate at 35,000 RPMs, and when operated at that very highest speed, it has a variety of levels of support, can be associated with significant hemolysis. But there's a whole new family of catheters that are now percutaneous applied technology that are referred to as two groups, both the pullers, meaning that they reduce right ventricular preload by several mechanisms. On the left, the precardia device, rather astoundingly, actually inflates a balloon in the superior vena cava, thereby gradually reducing preload into the right ventricle, and has been shown in a very small pilot study proof of concept to actually have very significant benefit that reduces probably secondarily renal vein pressure and filtration gradient improvement. The second one, as you can see, the magenta device is placed directly in proximity to the renal veins to actually pull blood away from them, reducing that retarding pressure of a high renal vein pressure. And the Dorea catheter, a similar type of mechanism and design, the so-called pullers, as opposed to the pushers, which are designed to enhance blood flow directly into the kidney. In a series of devices, the first of which is the CardioBridge device, which is an impeller-driven pump placed in this situation in the upper third of the descending aorta, thereby minimizing any risk of stroke. The second is the microaxial pump, referred to as the Procerian aortic. And the third is another impeller-driven pump placed in the descending aorta, only 10 centimeters above the kidneys, the second heart assist device. First clinical results that document the improvement that can be achieved with these catheters is the CardioBridge device trial, which was reported in 2019, a series of 16 patients who were very sick with severe biventricular heart failure, who had not only failed intravenous diuretic therapy, but 50% had failed intravenous inotropic therapy. Their mean urine output, despite this ongoing use of diuretics, was only about 60 cc's per minute. With the initiation of the pump, the urine output improved dramatically to over 250 cc's by 12 hours of use, and tapered off to a total of 4 to 5 liters in most of these patients at the end of 24 hours. Also had significant improvement in cardiac index, and importantly, no change in serum creatinine. The second device that I mentioned is this microaxial flow pump, a mechanism similar to the Impella device, which is placed in similar proximity somewhere in the mid to lower third of the descending aorta and operates at approximately 25 to 30,000 RPMs and has been associated with clinical data that suggests that it can also improve urine output. This is a pilot proof of concept study during high-risk PCI support. And these patients came to the cath lab after a diagnostic catheterization and had a baseline urine output that was somewhat variable, but relatively low. And I think, as you can see, during the 60 to 90 minutes of support during the PCI procedures, there was a rapid increase in urine output, documenting that these catheters can deliver significant improvement in blood flow directly into the kidney. The third device is the second heart assist device. It too is an impeller-driven pump placed in the descending aorta. As you can see, it is a pump mounted on a drive shaft placed inside a stent cage, which is importantly a stent very similar to the Town stent graft in that it applies a uniform radial force along each of the struts and provides any protection from movement during its use. This is a video of its deployment in which the catheter sheath is pulled back with the use of the hand-controlled knob, exposing the stent to fully open position. The second knob opens the impeller blades to full, and a control knob on the console adjusts pump speed. At the end of the case, the blades are secondarily collapsed completely. The knob reverses direction and allows the sheath to completely cover the stent, and then the entire device can be removed. In its employment at the use of acute PCI support, it took less than 2 minutes after arterial access was gained to deploy this only 13.5 French catheter system. This is a look at the device in situ, somewhat grainy film, but this was actually during the PCI procedure with the second heart assist device in place. This is, again, its appearance during the high-risk PCI support, which was done through the radial artery, but it's been very clear if you simply reverse and collapse the stent and the blades, you can pass coronary interventional catheters, do the PCI if you needed to switch to a femoral approach or for whatever reason wanted to start that way, then the PCI technology can be removed and the stent either re-expanded during the conduct or at the end of the case. Proximity is only 10 centimeters above the renal arteries. This catheter system too showed a very similar increase of almost fourfold increase in urine output, but impressively, this was during and following 3 IV contrast loads within 24-hour period, including a very large IV contrast for a diagnostic coronary angiogram to document they had high-risk coronary anatomy warranting intervention the day before this study was done. The day of the study, despite having documented prerenal azotemia by lab and low urine output, they had a second intraarterial contrast injection to document aortic diameter. This was followed by a third IV contrast in 24 hours to perform a 2 to 3 vessel target PCI procedure with significant contrast exposure again. And yet, despite these extensive contrast exposures, there was a significant improvement over the 60 minutes of catheter support in terms of urine output, but very impressively, the day following the procedure at the time of discharge, there was no change in measured serum creatinine from the baseline at the time of the study. So it is the easiest insert in that it takes less than 2 minutes and it does not require precise location, just the tip at the level of the diaphragm. It operates at the very lowest speed of only 7,500 RPMs versus the 25,000 for the aortic Procerian and 30,000 to 35,000 for the Impella pump, and does provide a documented 2.5 liters of additional flow, which represents potentially as much as a 50% increase in renal blood flow. But the field is going to change even more in that there's been a new second generation of the second heart assist device, which will become totally wireless and additionally impressively waterproof. This has entailed only a small increase in length of the tip of the catheter, which has a very impressive titanium shield over an inductive coil, which is where the device will be capturing the external power source, and has developed an impressive technology using a magnetic ball such that the same catheter drive shaft that delivers the stent into position will be simply demagnetized and the entire sheath being removed, and this resting in situ 10 centimeters above the renal arteries for long-term chronic support in ambulatory class 3 to 4 heart failure patients. These will all be performed in the cath lab with an estimated projected volume of use of over 300,000 cases in the United States alone. So in summary, the catheter-based treatment of advanced heart failure is really a paradigm change. It's no longer only a surgical discipline for advanced heart failure, and significantly more options for these catheter-based therapies are evolving every day. It's a very large growth area for interventional cardiology, and many of these, in fact, most of these will be placed in the descending aorta or proximity to the kidneys. The indications for use of these catheters will not only include during high-risk PCI support, but elective PCI in patients with chronic kidney disease to avoid nephrotoxicity and contrast-induced nephropathy. But it will be impressive for the acute heart failure and cardiorenal syndrome, as I've shown you today. But also in the future, the biggest expansion in the cath lab will be all these patients getting chronic ambulatory heart failure therapy, as well as those patients because of the improvement in distal flow with peripheral arterial disease and chronic limb ischemia. Thank you for your time.
Okay, Annie, it's all yours. Go ahead. We cannot hear you. Can you unmute yourself, Annie? Unmute yourself, Annie, please. We cannot hear you.
All right, now can you hear
Here
me?
we go. Yes, yes, go ahead.
Okay, I'm going to share my screen. So here we go.
Please go ahead.
And organizers, if you need to help me, maybe get those slides on there. I'm having a little difficulty with the slides. Let's see. All right, Omar.
Okay, go ahead, ready?
Yeah, I'm having a little difficulty sharing the slides.
If you want, can we go for the next?
Yeah, let's go for the next one. And then Praveen, maybe you can help me with getting those slides up there for my talk.
Bismillah ar-Rahman ar-Rahim, Mr. Chairman, my dear colleagues and professors. It's my great pleasure to be a part of the faculty. I'd like to thank first the Dr. Omar Halak and the organizing committee for inviting me to present this lecture in the key points and paradoxical low-flow aortic stenosis, diagnosis, imaging, and intervention. There is no conflict disclosed for this presentation. I will start an introduction to is the most popular equation that we are using until now, and the aortic stenosis is the continuity equation. And this continuity equation, you will be able to calculate the aortic valve area. The principle of aortic the principle of the continuity equation is the amount of flow before the valve or the left ventricular outflow tract is equal the amount of flow across the valve. And so the aortic area, depending on proper measurement of the LV outflow tract or the annulus of the aorta, and also the tissue velocity integral of the flow, and then have been divided by the aortic tissue velocity integral. So it is very important to accurately assess the annulus of the aortic valve area, because if you are measuring the annulus in this wrong place, the aortic valve area will be 0.4, very severe aortic stenosis. But if you are measuring it properly, it will be almost 1 centimeter square centimeter. This is how you can see the difference in just improper measurement of the outflow tract. So you measure through the parasternal long axis view the annulus in the M mode, and then you can go to the 5-chamber, apical 5-chamber view, and measuring just before the valve heal the using the pulsed wave Doppler to measure the left ventricular outflow tract TVI. And then you can use the continuous wave Doppler in the same position, apical 5-chamber, to measure the flow in the aortic valve and the tissue velocity integral. This is the classification of aortic valve severity according to the ESC guidelines and AHA-SC guidelines. According to the aortic jet velocity, if below 2.5 meter per second, is considered to be minimal or even normal, and mild stenosis is between 2.6 2.9, and the severe one is more than 5 meter per second. In between is the moderate one. And if the mean gradient exceeds 40 millimeter mercury in the ESC guidelines, it is severe aortic stenosis, and it is more than 50 in American ASC and HA guidelines. The aortic valve area, if less than 1, it is severe, and 1 to 1.5 moderate, and more than 1.5 mild. And the index aortic area should be below 0.6, so it should be 0.5 to say severe aortic valve area, the index, which is very, very sensitive and highly specific to detect severe aortic stenosis. So if any discrepancy between the pressure gradient, as example, pressure gradient below 40 millimeter mercury, and the aortic valve area, we should think of low flow aortic stenosis. So sorry for this, if you have a low gradient and very small aortic valve area, less than 1 centimeter square area, or index area less than 0.6, we can think for low flow aortic stenosis and paradoxal low flow aortic stenosis. This is an example of any technique. You can see the short axis and long axis. The valve is not opening at all. This is the flow acceleration with both aortic stenosis severe and aortic rigor, and this is in the short axis and the 2D echocardiography. There is no doubt about this patient that he have a severe aortic stenosis, and we use a 3-dimensional echo for confirmation. So once you see this limited motion of all cusps and a mean gradient of above 40 millimeter mercury, and this is the maximum gradient 67 millimeter mercury, this patient have definitely aortic stenosis. There is no problem about these patients. But sometimes the condition is more difficult to identify, and you can try to measure it in a short axis view. Sorry, again, come back. You can try to measure it in a short axis view. Using a 3-chamber, you can using this parasternal long axis and short axis view to assess it, and you can also need a 3D echo to confirm that the patient had aortic stenosis. But when we should use stress echocardiography in asymptomatic patient with aortic stenosis but have a low flow aortic stenosis, although this is not a patient with aortic, this patient have hypertrophic cardiomyopathy, but this is, I'm telling you how that hypertrophy of the muscle can change the flow in the outflow tract, and can be impaired flow in aortic stenosis. Simply when the ejection fraction is below 40 millimeter mercury, if the ejection fraction is below 40% and the gradient is less than 40 millimeter mercury, and the effective regurgent orifice area is less than 1 centimeter. So there is discrepancy between the gradient and the aortic valve area. So When using dobutamine echocardiography and the stroke volume increased by 20%, if the gradient increase to be more than 40 millimeter mercury and the effective regurgent orifice area is less than 1.2 centimeter square, this means true severe aortic stenosis. But if the gradient is still below 40 and the effective regurgent orifice area is more than 1.2 during the dobutamine stress echo, this means pseudo severe aortic stenosis. So increase in the aortic area and no change in the gradient or less gradient means pseudo. But if there is increase in the gradient and effective regurgent orifice area becomes going towards 1 square centimeter, we are speaking about severe aortic stenosis and low flow aortic stenosis. So in the majority of cases, they're usually the aortic valve area matching the gradient. But you should note that the gradient is flow dependent. So if the flow is depressed, the gradient becomes low. So small reduction in flow can cause great reduction in gradient. And this can happen actually in those patients who have myocardial dysfunction, secondary to dilated cardiomyopathy, ischemic heart disease, or hypertensive heart disease. Like in this patient who have dilated cardiomyopathy, the scenario, the patient have 72 years old man, with hypertension, dyslipidemia, coronary artery disease, complaining of difficulty breathing, class 2, and the gradient maximum is 44, mean gradient to 26, meaning the patient have moderate, according to the gradient, moderate aortic stenosis. But you will find here that the index aortic valve area is 0.5 square centimeter, means severe. So it is a candidate for dobutamine echocardiography. If the gradient increase and the aortic valve area remains low, this means the patient have true aortic stenosis or low flow severe aortic stenosis. So a mismatch between gradient and valve area, we should look for indexing to body surface area, which become more specific to diagnose stenosis. And you should look for re-evaluation of the left ventricular outflow tract diameter, maybe inaccuracy in calculation of the outflow tract diameter, like in my first slide. So who said that aortic valve area less than 1 centimeter less corresponds to a gradient of more than 40? So a low flow state defined as a stroke volume index less than 35 million. So this is the case scenario for another patient who have a normal ejection fraction, but the gradient also is not so severe. The mean gradient 28, considering moderate stenosis, but the index aortic valve is 5, and he's to sudden death. So we should look carefully for this patient, and we should evaluate if the patient have low flow secondary to low ejection fraction, or due to myocardial dysfunction, and whether this myocardial dysfunction is secondary aortic stenosis or secondary to other causes, or primary myocardial disease need to be evaluated. So we first, there is a suspicious when the gradient aortic valve area mismatch during routine echo. If the gradient less than 40 millimeter mercury, aortic valve area less than 1, and ejection fraction below 40, we can consider dobutamine stress echo to diagnose low flow aortic stenosis. But how to assess cardiac function in paradoxical low flow aortic stenosis with normal ejection fraction? This is called paradoxical. This actually is a new entity, and now the low flow can also be secondary to preserved ejection fraction. Heart failure with preserved ejection fraction. Actually, during the last few months, we published this important thesis in echocardiography journal, the pre-heart failure at 2D and 3D speaker tracking echo. And I was actually the corresponding author in this one to diagnose the cardiac dysfunction, even with normal ejection fraction in different diseases, including valvular heart disease and specifically aortic valve disease. And we can actually assess the the severity of aortic valve stenosis, even in the presence of normal ejection fraction and low gradient. This patient have a normal ejection fraction of 51 almost, but the global strain here in the bullseye showing depression of the global strain to minus 13 only. Another important data here, which is the rate of pressure development is also depressed, measured it here in the first, second, and third second from the mitral incompetence slope, and you find it is 600 millimeter mercury. It should be more than 1,000 or 1,200 millimeter mercury per second. So there is two parameters indicating depression, intrinsic depression of myocardial function in aortic valve disease in the presence of normal ejection fraction. So this patient also should be going to search to aortic valve replacement. And another way is to measure. So the last slide is called myocardial performance index. And now the index of myocardial performance here, when you can assess also the cardiac dysfunction by another way of measuring the IVCT with the the relaxation time, the contraction time, and the relaxation time over the ejection time. This spread over the ejection time to evaluate the cardiac dysfunction. So treatment decision depend on the triad of chest pain, difficult to breathe.
All right, I think we're back. Yes, team, since we're having a little difficulty with the share button, can you please upload my slide? All right. So anyway, I want to just say this is such an honor and a pleasure always to be with Dr. Halak and Dr. Krazier at the 4TS, and this is the 8th 4TS, and so exciting to talk about enhanced external counterpulsation therapy in COVID times. I am an interventional cardiologist trained at the Texas Heart Institute, and I love preventive cardiology. I help teach at Baylor University, and I have a lot of interest in coming to Dubai and teaching also with regard to preventive cardiovascular care. Next slide, please. All right, the target population for external counterpulsation therapy has been coronary artery disease patients with angina pectoris, and also in those patients with heart failure. Just want to make sure that I have, I'm timely for you guys, so I'm putting on my timer. Next slide, please. Now, ECP therapy was covered by Medicare quite a long time ago here in the US. For those patients who are inoperable, high risk, their coronary anatomy was not amenable to surgical procedures, and also for heart failure. And we're going to talk, next slide, we're going to talk about the potential for use of ECP in the time of coronavirus, because we know that COVID affects the cardiovascular system, multiple areas with regard to myocardial infarction, stroke, heart failure, arrhythmias. And next slide, please. We're going to talk about, in particular, what happens with COVID-19 and how does ECP help that. We even see large vessel stroke as a presenting feature of COVID-19, even in young patients. So we are living in a different world and time with atrial fibrillation occurring in about 23 to 33% of COVID patients, and that's a recurrence of AFib and new AFib in about 10% of patients. And there are multiple mechanisms of this with regard to inflammatory changes, signaling with cytokine storm, causing arrhythmias. And next slide will show that there are ways to evaluate that with wearable devices, ECG monitoring, looking for silent atrial fibrillation. Clinical trials have shown that even wearing biosensors can find in 11% of patients evaluated combined AT and AF. So silent AFib is quite important in these post-COVID-19 patients. Next slide, please. There are new wearable biosensors that are free of wires, and that's very exciting for me to talk about. Next slide shows a wonderful patch that's available now in Dubai as well as in the US and multiple areas around the world. 2 leads evaluating the patient for 5 to 7 days, and so we should really be aware of these things to look for silent arrhythmias in our post-COVID patients. Next slide. Why does this happen? We're going to talk about the coronary hemodynamics and how does ECP help our patients? We know that coronary blood flow is best in the diastolic phase. Next slide. ECP procedure is a series of 3 cuffs wrapped around the calves, lower thighs, and upper thighs and buttocks. And multiple times I've spoken about ECP, so you can refer to those previous lectures. I won't give you all the history on that. But we see increased diastolic pressure and retrograde aortic flow and systolic unloading with an increase in cardiac output up to 25%. Now here's okay, we're going a little fast here, boys. Let's go back one slide. Okay, next slide, please. A total of 35 hours, and benefit is even seen at 2 weeks, and usually our treatment is 35 sessions. Next slide. There's a great history of ECP from the 1950s all the way through the 80s. Multiple clinical trials were done, and even up to recently, November 2019. Next slide, please. Some of the early studies were multi-center studies showing reducing time to ST segment depression and episodes of angina. So that was a great clinical trial by Aurora. Next slide. The International ECP Registry showed we could actually change the Canadian class of these patients from class 3 and 4 heart failure down to class 1 and 2. So that was a very impressive data. And this was so many years ago. So we know that ECP benefits. Next slide. So Soren and associates showed improvement in exercise tolerance with ECP. With those patients were average ejection fraction of 23%. Next slide. All right, so even the ACC-AHA guidelines mention ECP, which is so exciting, that is considered for relief of refractory angina in patients with ischemic heart disease. Next slide. In November 2019 in Circulation, this was published, where they looked at ECP patients plus ranolazine. So adding ECP to ranolazine, what was the conclusion? That ECP improved markers of functional capacity independent of baseline ranolazine therapy. So the clinical benefit is likely driven by the differing mechanisms of action for ECP. So next slide, please. There's a weight of clinical evidence. We know that it's safe and effective. Next slide. But how does it help with COVID-19? COVID-19, oxidative stress. These are really powerful words that we all need to know now in this post-COVID era. Next slide. Endothelial injury is the most important part of what COVID-19 does to our bodies. Mechanisms are such that next slide shows, and this is a great slide from the Texas Heart Institute showing SARS-CoV-2 increasing interleukin-6, PI1, and TPA, and decreasing TPA, and therefore increasing thrombosis. So cytokine storm is causing this endothelial dysfunction, and that's a key to early atherogenesis, and endothelial dysfunction can be found to cause many dysfunctions within the blood. Let me see the next slide, please. All right, nitric oxide is very important. So with COVID-19, it beginning as an acute respiratory distress and moving to the vascular networks, we see a decrease in nitric oxide production, and therefore nitric oxide is not there to interfere with the interaction of coronavirus, the S protein and the host receptor ACE2, and that's really critical to prevent viral entry into the cell. Next slide. The pulse cardiac test is used worldwide to evaluate endothelial damage and inflammation. So I really ask all of you to learn about the pulse cardiac test. I use it all the time in my practice, both in the US and Dubai. Next slide. Because it's like a check engine light. We can know what are the inflammatory markers in the blood, and how does this differ from C-reactive protein? Next slide shows that C-reactive protein sensitivity is about 35%, whereas the pulse biomarkers sensitivity of 73%. So really great blood test to look at endothelial dysfunction. Next slide. COVID-19 receptors, as I said, the spike protein is attaching to the ACE2, and that's mainly expressed in vascular endothelial cells and arterial smooth muscle cells in all organs. And next slide, please. Consequences of COVID-19 are such that we see severe endothelial damage, pneumonia, blood clotting, heart attack, stroke, and the pulse test can actually guide us in evaluating early on, is the patient at risk for these types of problems post-COVID. Next slide. Even after the COVID vaccine, we can see anaphylaxis, thrombosis, Guillain-Barré. So even the nervous system can be affected post-COVID-19, all because of this endothelial dysfunction. There are two levels of benefit using ECP for prevention and early treatment of endothelial dysfunction, reversing platelet endothelial dysfunction and thrombosis, and lowering viral burden. Next slide. All right, the mechanisms of chronic oxidative stress are are well known, and endothelial cells play a great role in this problem. And the mitochondria are the key. They're actually promoting cardiovascular disease and lung injury after recovery from COVID-19 because of this feedback loop that perpetuates mitochondrial dysfunction and inflammation. And this can be actually improved by antioxidant therapy, such as IV vitamin C, as well as enhanced external counterpulsation. The investigator Sackner showed that pulsatile shear stress is a wonderful mechanism to provide similar benefits of the gentle jogger model, where the pulsatile shear stress is helping the vascular endothelium monolayer to increase nitric oxide production.
Sorry, Annie,
I know. Keep going. One more slide. So we see benefits of ECP by increasing things such as prostacyclin, TPA, glutathione peroxidase, and catalase. And I would like to, I know that I'm not finished with my slides because it's a live presentation, but think about ECP to help in the post COVID-19 patient. Thank you.
Great presentation. Excellent. Thank you so much. We'll go for next one.
Next one, please.
Next presentation, please.
Good afternoon, ladies and gentlemen. It gives me great pleasure to be able to present my interesting case in front of this elite conference. I'm Professor Dr. Yasser Menesi, Professor of Cardiothoracic Surgery at Cairo University, Egypt, and a consultant cardiac surgeon in Dubai, UAE. I'm going to present a case where myocardial infarction has been complicated with an ischemic VSD. This is a 50-year-old gentleman who is known to be a heavy smoker and diabetic type 2 for the past 20 years. He suffered an attack of prolonged typical chest pain. The pain lasted for several hours and disappeared spontaneously, so he did not seek medical advice and stayed at home. 14 days later, he presented with progressive shortness of breath and abdominal tenderness. Physical examination revealed a blood pressure of 90/60 millimeters mercury, regular pulse at a rate of 110 beats per minute, elevated jugular venous pressure, and tender pulsating hepatomegaly. A loud precordial pansystolic murmur and thrill were noticed with normal heart sounds. Now, this is his ECG. It showed the pathological Q waves in lead 3 and AVF with deep symmetrical T wave inversion in the inferior leads. There is as well a left atrial abnormality. The echo demonstrated a large myocardial aneurysm involving the inferior wall and posterior ventricular septum of the left ventricle, ischemic ventricular septal defect with left to right shunt, and moderate posterior pericardial effusion. He had a normal left ventricle dimensions and good overall systolic function with an ejection fraction of 63% and mild mitral regurg. This is an echo image showing the defect between the left ventricle and the right ventricle. His laboratory evaluation was unremarkable apart from a high INR, which was 2.3, and it decreased to 1.2 after 2 days of discontinuing warfarin, which he was taking due to a previous AF. It was actually a paroxysmal AF. Coronary angiography was done, and it showed a critical proximal LAD lesion, as well as a totally occluded right coronary artery. Left ventricular injection showed the inferior left ventricle aneurysm, as well as the ventricular septal defect. The patient was transferred to the operating theater for CABG, repair of the ischemic VSD, and aneurysmectomy. After opening the sternum, we opened the pericardium to find the right atrial appendage markedly congested and peeping through the pericardium after we opened it. After establishing cardiopulmonary bypass and collapsing the heart, we elevated the heart to check the inferior wall, which was quite thin, and this was the site of the aneurysm. I opened the site of the aneurysm, which was very thin-walled, and it's evident here that the edges are like 2 or 3 millimeters, while the normal left ventricular thickness should be 9 or 10 millimeters. And through the defect in the ventricular septum, I was able to put a right angle which passed from the left ventricle into the right ventricle. This is a more clear image of the VSD and the thin wall of the left ventricle. And this shows the VSD, where I put the non-toothed, and it's clear that there are edges, especially on the inferior side, where there is degenerated ischemic tissue. I trimmed this ischemic tissue, part of the ischemic VSD, and then started taking my stitches to close the VSD. They were all interrupted stitches, Prolene on Teflon pledgets, because the edges are ischemic and it's not like healthy tissue. So I had to take all the stitches interrupted on Teflon pledgets. After closing the VSD, I had to close the edges of the left ventricle, and it's usually closed in over Teflon felts, those white strips on the right and the left side, in 2 layers. First, transverse mattress stitches with Prolene, and it's tied on the Teflon felts, followed by a second layer of a continuous Prolene through and through to secure the left ventricular opening, because of course this left ventricle creates significantly high pressure of 120 or 130. So this has to be closed on 2 layers. This is a close look after the first layer was done of the transverse mattress stitches. And then I was gonna start the continuous through and through Prolene. This is the Lima anastomose to the LAD just before cutting the Prolene stitch. Now, it's worth noting that there's a difference between closing a congenital VSD and closing an ischemic interventricular septal rupture. The congenital VSD is surrounded by a healthy interventricular septum, while the ischemic septal defect has at least half of its circumference surrounded by ischemic necrotic septal muscles. So the necrotic edges must be trimmed first so as to put the sutures in normal septal muscles. And all the sutures should have Teflon strips to prevent cutting through of the sutures. It's worth noting that the 30 days mortality rate for a normal risk CABG surgery ranges from 1% to 3%, while these risks rise to 5.7% to 16.9% in CABG with left ventricular aneurysmectomy, and the risks jumps to 27 up to 47% in CABG with VSD repair. Thank you.
Well, that was, we were running a bit out of time, so supposed to have 10-minute discussion. I think we were able to have 2-minute discussion only. If I don't know if Dr. Roger's still there or you gave up. Joseph still here?
I think Dr. Rogers had to leave at the top of the hour, as he said.
Okay.
So,
Just a quick question, Dr. Miller, for heart failure in COVID patient, right heart failure and left heart failure in 1 minute. What do you do special for them?
I think it really.
I meant cardiogenic shock, right heart failure and left heart failure in COVID.
Yes, I think there's really, I don't differentiate it with COVID as the theology. I think there are several systems that function independently, CenterMag and other devices that can be applied equally to individually, the right side, left side, or in tandem. But at least at this juncture, I have not seen any data suggesting that the approach in COVID patients is different than those without COVID infection.
Quick question for that second heart or those pillar and pusher. Do they lower the blood pressure when they kind of pulling the blood out of the aorta? Does the blood pressure drop further or?
It's an important question. It's only relevant to the so-called pushers because particularly the impeller, but also the microaxial pump, when activated, the impellers actually pull blood down through the impellers in the pump to be propelled below the device. That we actually set the RPM speed to allow a 10 millimeter reduction in proximal aortic pressure. There's an extensive amount of data that says it does not induce arterial steal in the coronary or cerebral circulation, but provides very significant afterload reduction such that the hemodynamics in that CardioBridge study showed an increase in cardiac index from a low of 1.8 before the study began to a high of 2.4 in 24 hours with nothing else done, showing how important that afterload reduction can be in improving cardiac function.
Absolutely, and you may, possibly add pressors also for the hypotensive patient. I'm sure.
I have not had. This has been a somewhat electively applied therapy right now for people with, advanced heart failure, but not in hemodynamic compromise.
Okay.
Omar,
I
just want to say thank you for letting me be with the Hall of the Giants here. Thank you, gentlemen. Such an honor.
You did a great job.
To be with you all.
You did very well.
I do want to say that my real lecture will be uploaded on my website, drnev.com, so people can see all the slides.
I think that's perfect. We're going to upload the whole lecture on the website also for TS, so we'll have people to have a chance to look at the whole thing. I really would like to thank all of you. It was a great presentation, and Dr. Roger also have a great presentation. Thank you so much for being with us in this session. I wish we have a little bit more time for discussion because that make it more beneficial, exciting. But unfortunately, we have to go on for the next session, which we are about 3 minutes late. Thank you so much. We'll see you again, inshallah.
Thanks to you, Dr. Omar. Thank you.
Thanks.
Thank you.
All right. Let's see. Complicated cases.
Yeah.
And
now all yours, Dr. Annie. You can
all
go
right.
ahead.
We know that complications in cases are always good to see because those are nightmares for us. And Dr. Halak, he's going to open up with a complication case, and Dr. Sievert from Germany, Dr. Mahmoud from Syria, Mohammed Zaidan, Dr. from USA, and Dr. Evan Schlafmitz from USA, and Dr. Deepak Jain from Germany, as well as, again, Dr. Mohammed Zaidan. So we have a chock full of data, interesting findings, cases. So let's get to it. Our team, can you help us with the first talk?
Hi, my name is Omar Halak. I'm an interventional cardiologist and head of cardiovascular department at King's College Hospital, Dubai. I'm going to present the first case of this session. It's a simple case, brief case. Just to show that a simple coronary intervention can become a catastrophic event. This is a 57-year-old male smoker, hypertensive, and this epidemic. Have history of MI 7 years ago, multiple intervention to LAD, circumflex, and RCA in different dates. The last intervention was several weeks ago. He presented to emergency room with acute coronary syndrome. ECG showed sinus rhythm with non-specific STT changes. Cardiac enzyme were negative. Because of persistent chest pain, patient was taken to a cath lab. As you can see, the RCA, there is a multiple ectatic area. There is a stenosis here, probably significant. There's some other multiple stenosis. Second view, there may be a little bit of haziness in this area here. But regardless, there's no critical stenosis. Well, after a second injection, a patient started complaining of chest pain. And the pain got worse. Angiogram shows occlusion of the RCA. I tried to find if there is any dissection here, but I don't really see any dissection. Even the catheter tip is can be creating a dissection, but I wasn't able to find a dissection here. And also, it doesn't look like there is thrombus or air embolism in there. I wasn't sure why this artery closed down. It's a black rupture, or probably will hear from the panelists and from you. What do you think? Anyway, patient got worse. Patient became hypertensive quickly. Actually, within really less than a minute, in about a minute or so, and started to have ST elevation. So catheter was exchanged to guiding catheter, wire put in, and a stent was placed in, and restoration flow was obtained with good angiographic results here. The reason I brought this case, it's a relatively simple case, but just to bring the point that regardless of the level of experience, a simple case can be catastrophic. Always we need to follow the standard safety tip. Before starting any procedure, we need to be really well prepared just in case something goes wrong. That include cover stent and all other devices and equipment we need to handle any possible complication. The key things in this complication is to keep calm. That is really important, to keep calm, and almost always things will be fine. However, always call for extra help immediately before things getting spiraled down, because we don't know how the thing will progress. And of course, explain to the patient what happened. Well, this is a simple presentation. I'm sure we're going to have much more complicated cases in this session. Thank you so much for your time.
Thank you very much to the organizers for inviting me to speak about a very important topic, and that is why and how cardiologists should become involved in acute stroke interventions. These are my disclosures. So really the breakthrough in catheter therapy of acute stroke have been these stent retrievers. They basically work like you can see here. So this is a clot in the middle cerebral artery, for example. Then it's crossed with a micro wire, and then a microcatheter is introduced into the distal part of the vessel, and then this stent-like device is introduced through a microcatheter and this goes into the clot and embedded the clot, and then finally you can pull everything out. So the stent retriever together with the clot is sucked into the guiding catheter. So this was really the game changer in acute stroke interventions. Another important change was to use aspiration catheters, like this example is a penumbra catheter, a large borehole catheter where you can aspirate the clot directly from intracranial vessels. So between 2015 and 2017, 9 positive randomized trials have been published, and they basically all showed that lysis plus thrombectomy is superior to lysis alone in large vessel occlusion. But it's important to remember that time is brain. In each minute, we lose about 1.9 million neurons, 14 billion synapses, and 2 kilometers of nerve fibers. And the subgroup analysis of those trials published in 2015 showed that if we can reopen a blocked brain artery within 2 hours, recovery rate is 90%. And if we are able to open it only after 6 hours, recovery rate is only 20 to 30%. Well, who should do these interventions? Ideally, a comprehensive stroke center, trained neurointerventionists, 50,000 procedures minimum, 30 years of training in invasive therapies, 20 CME courses per year, on call every night, a team approach where neurosurgeon, neurointerventionists, neurologists, psychiatrists, physical therapists, and vascular surgeons are all at patient's bedside in the ambulance. So this is our highly trained neurointerventional team. I will show you some statistics from the US. They have about 800,000 strokes per year. There are about 200 neurointerventionists in the entire country, which means 4,000 strokes per year per neurointerventionalist. Well, not all of them will need an intervention, but all of them will need an interventionist on call. But there are more than 10,000 interventional cardiologists, radiologists, and vascular neurosurgeons who also could learn and do these procedures. Well, cardiologists are, as you know, almost everywhere. They have the infrastructure for emergencies. They have the cath lab, they have the staff, they are on call anyway, and they can and have to be involved in acute stroke interventions. I will show you a case example. This case is a young girl born in 1998. A 16-year-old girl, lives in a small village close to Frankfurt, goes to high school, 10th grade, would like to study medicine, but she's not sure whether she can make it into medical school. On Tuesday, August 11, 2015 was her destiny day. In the evening of that day, she suffered from sudden weakness of her right arm, followed by complete hemiparesis. Awake, but she could not speak. Her mother, with the help of neighbors, managed to bring her into the emergency room of the St. Catharinen Hospital. Complete hemiplegic at the time of arrival, could not speak. CT showed still normal findings, which is typical for an acute stroke. CT angio showed middle cerebral artery occlusion. Door to lysis time was only 22 minutes, so very fast, but there was no clinical improvement. And then a discussion with the mother about the different options. Remember, this was before the randomized trials had been published. Neuro called me at 10:09 p.m. There's a big stroke, 16-year-old, can you help? And this is the patient on the way to the cath lab. And they said to the mother, please wait here, I will come back to you. This is at 10:12 p.m., the arrival in the cath lab. The angiogram showed middle cerebral artery occlusion as seen before by the CT scan. And this is at 10:34 p.m., 20 minutes after the stroke call. There's a whisper wire inside of a microcatheter in front of the middle cerebral artery occlusion, right here. And after deployment of the solitaire, which is a stent retriever, even before clot removal, there was respiration of flow. You can now see that the distal parts of the middle cerebral artery are well perfused. This is 33 minutes after the stroke call, the clot was removed. And she said, ich kann wieder sprechen, which means I can speak again. Jetzt die Hände so nach oben stellen, Augen zu machen.
Ich kann ein bisschen schwer das zu bewegen.
So she had a complete recovery. If nothing else bad happens, she probably has 60 to 70 more years of a normal life ahead of her, instead of decades in a wheelchair. I will show you a case example from the other end of the spectrum. So this first patient was 16 years old. This one is 89 years old. Left hemispheric stroke, arrival in the emergency room at 9:26 a.m. IV lysis was started, call from neuro at 10:25, left internal carotid occluded. Arrival in the cath lab at 10:30. Puncture of the right femoral artery at 10:35. Difficult aortic arch type 3, kinking of the left common carotid artery, and the question is how to get access here. I used the SIM3 catheter. No catheter or wire could be advanced further. You see the kinking of the proximal and common carotid artery. What to do now? Well, we did a direct puncture of the left common carotid artery. You see the angiogram here, a 4 French radial sheath exchanged for a 6 French sheath. Access was a challenge in its own. Under time pressure, every minute counts, patient unconscious, not cooperative, moving around. Somebody had to hold the sheath in place all the time. No assistant, only one nurse in the cath lab at that time of the day. Kinking of the proximal internal carotid artery, as you see here. Occlusion of the distal internal carotid artery at the skull base. Internal carotid artery straightened by wire and microcatheters, and this caused this kinking here. A Sophia 6 French aspiration catheter advanced into the distal internal carotid artery. Aspiration catheter advanced into the clot, but nothing could be aspirated. Then I used a 6 mm, 4 cm solitaire, which is one of these stent retrievers. Removal under aspiration together with the aspiration catheter, and this is what came out. After clot removal, blood pressure suddenly dropped to 60 millimeters of mercury systolic. And you can see EKG changes. So the CPR team was alerted. Intubation, ventilation. We performed a coronary angiogram showing the sheath, using the sheath in the groin. There was a tight stenosis of the right coronary artery. Or was it also clot? I don't know. We used a 4 mm DES. And here you can see EKG and blood pressure comes back to normal. Let's go back to the brain. Internal carotid artery open. However, the anterior cerebral artery is also open. However, the middle cerebral artery is still occluded. 2 minutes later, you see some flow in the middle cerebral artery, but still stenosed. What else is not good here? Well, is there a stenosis in the distal internal carotid artery right here? Or is it maybe clot? 2 minutes later, you see reocclusion of the internal carotid artery and or the middle cerebral artery. I used another solitaire 6 mm, 4 centimeter long, and this is after removal of solitaire and aspiration catheter. Full perfusion of the intracerebral vessels. Puncture site was closed with an angioseal. Back to the heart. Left coronary artery, stenosis of a diagonal branch. I left this alone, medical treatment. And the key points are here. In acute embolic stroke, embolectomy, in addition to IV lysis, has become the treatment of choice. It's a class 1A recommendation. It can and should be done up to 6 hours after the onset of symptoms, in selected cases up to 25 hours, but every minute counts. Time is brain. Cardiologists can and should become involved. How to learn acute stroke interventions? Read the literature, get some initial experience in angiography of supraaortic vessels. Learning how to do carotid stenting is of course helpful. Attend carotid stenting and stroke courses, like for example, our ICCA stroke course, which is currently virtual. how to learn, and then attend these courses, and then simulator training, observation in big stroke centers, and ongoing evaluation of procedural outcome. To facilitate this, we have founded the World Federation for Interventional Stroke Treatment. So if you're interested, we can connect you and help you with training and education in this field. There's also an on-site course in Frankfurt again in September 9 to 10 this year. Thank you very much for your time. Time is brain.
Hello, I'm Dr. Mahmoud Al-Kutaish, interventional cardiologist at Al-Bassel Heart Institute, Damascus, Syria. I'll present to you a case about left main dissection. This patient is a 40 years old male, present to the emergency department with the typical symptoms of ACS. Angiography showed a severe lesion in the OM1, which is intermediate, and a severe lesion in the OM2, which is the culprit, and a severe lesion in diagonal artery. The LAD was without significant disease. So this was the left system, and here we see the RCA was severely diseased in the mid segment, about 80% stenosis, and BCI was decided for this patient, starting with a OM2, which was thought that it's the culprit lesion. The OM2 was BCI'd by a direct drug-eluting stent, and the result was very good for the OM2. Here we can see the severe lesion in the intermediate. The wire was out, and I reinserted the wire to the intermediate artery, and the focal DAS was implanted in the first segment with a good result. Now, and after taking control views to the left system, we noticed a white line in the left main, and with contrast injection, the dissection continued and extended to the LAD. Here we can see the dissection in the LAD, and disseminated to the diagonal, to the LAD, and to the beginning of OM, and to the circumflex artery. And the wire was out, which was a BMW wire, and I reinserted the wire to the end of LAD. Then I implanted a direct onyx 4 multiplied by 13 in the left main, protruded to the aorta 2 millimeters and flared by its balloon. So the left main result was good, the hemodynamics was improving, and the chest main is becoming less severe. After that, I was confused to continue to BCI the whole LAD up to the third segment, because the dissection flap was disseminated and continued to the third segment. As we can see here, there's severe stenosis caused by the flap in the beginning of the third segment. So I decided to stent the LAD from the beginning to the third segment. This is distal stent, and this is the proximal stent to cover the entry of dissection in the LAD, overlapped with the left main stent, and up to high pressure with flaring for overlapping area. Here we can see a dissection area in the mid LAD, not stented segment. So I put a stent here in the mid segment of LAD, overlapping with the proximal and distal stents to cover the whole dissection. This result was very good, and the patient is stabilized, but there's a dissection flap in the diagonal and in the beginning of the OM and the circumflex. Those dissections were left for medical treatment, and the patient was put in the ICU for 48 hours on tyrosine infusion to see the improvement of the patient. As we can see here, there's a dissection flap in the beginning of circumflex and beginning of OM. Arteries were stented at the beginning, so no fear of dissemination and extension of dissection to the end of the artery. Then in the next 2 days, I repeated the angiography after 2 days on tyrosine infusion in the CCU. This was the view, the left system. The left main was very good. The LAD was very good with the TIMI3 flow. The stented arteries, who are the OM and the circumflex, were very good. And the diagonal was healed with its original stenosis. And everything in the left side was okay with the TIMI3 flow. As we can see here, all dissection flaps were healed. Then we transferred to the RCA. We did a simple BCI for RCA by direct stenting with a DAS. It's a very good result for RCA. And the patient is asymptomatic after this staged BCI. This operation and this procedure is about 1 year ago. Now the patient is coming back for checkup, and he did a stress test, which was normal. Thank you so much.
This is Mohammed Zaidan from Henry Ford Hospital, Detroit, Michigan. Today I'm presenting to you a case of coronary rupture. This is a 65-year-old gentleman with history of diabetes, hypertension, hyperlipidemia, presented with NSTEMI. Echo showed normal EF. Diagnostic angiogram was done, and it showed patient had obstructive LAD disease, more in the moderate range, Brox and mid, and then he had an ulcerated plaque in the mid RCA that was his culprit. Patient underwent PCI to the RCA with good results, with 2 non-overlapping drug-eluted stents that went very smooth and complicated. Decision was what to do with the LAD lesion, medical therapy, PCI, or physiologic study with FFR, or stress test later on. Decision was to proceed with FFR of the LAD. This is the FFR wire, and this is the FFR on pullback. Actually, we did IFR that was significant, was 0.86. And then we did confirm that with adenosine, IV adenosine, and his FFR was significantly positive at 0.71. So decision was to go ahead and PCI the LAD. Decision was to proceed with 2 overlapping stents with direct stenting the LAD, as it was thought that the plaque is soft and we will give to stenting only. So first stent was placed in the mid LAD, Immediately after the stent placed with the puff, there was a sign of perforation. So picture was taken before the balloon was taken out, and it confirmed that there was a perforation. So the balloon was re-advanced, inflated again to seal the perforation. This is a picture with the balloon up, make sure that we're completely sealing the perforation. A quick echo was done. It showed no effusion. Of course, with the balloon up, patients started having chest pain, ST elevation. We had to go down on the balloon. After a couple of minutes, repeat angiogram with a different view showed that there was persistent contrast leak. You can see the contrast actually is going to a chamber, most likely the RV. So the perf happened in the myocardium to a chamber with that's the RV. So what to do here? Taking consideration that we're not able to see the perforation with balloon, only with the prolonged balloon inflation, decision was to go ahead and put a covered stent. So a covered stent was placed. We chose a shorter size to make sure that we don't occlude those diagonals. We placed the covered stent inside of the drug-eluted stent. And this is the angiogram after the cover stent was able to completely seal the perforation. Ended up putting proximal stent to treat the proximal lesion. See that the perforation sealed with the cover stent. And this is the final angiogram. Both diags held up. There's some old contrast hanging there, but there's no active extravasation. This is the different view. Repeat echo showed no effusion. Patient did well hemodynamically. Looking back, why this perforation happened, looking at the diagnostic angiogram, there was a myocardial bridge that was underappreciated. So if you look at this picture, you could now see the myocardial bridge in the mid-LAD and going up with direct stenting into that bridge caused the perforation. Usually the bridge segment in the LAD is smaller than the reference vessel before and after. There's a higher risk of perforation reported in the literature with stenting of myocardial bridge. Of course, the patient did well, but later on, a few years after, he had recurrence of angina and he had a positive stress test in the LAD. So this is his repeat angiogram 4 years later, and you could clearly see that there was ISR in the covered stent with progression of disease in the Brock's LAD, almost close to the ostium. So what to do now? Patient had a covered stent in the LAD. He has some progression of disease in the LAD. His RCA and circ were free of disease. The stents in the RCA were beautiful. There's no further progression of disease in the RCA. So taking consideration the high recurrence rate of ISR in the bridge, no intervention was done, and patient was referred for robotic Lima to the LAD, and he did very well with that. So stenting in myocardial bridge is usually like to be avoided as much as possible, as there is a higher rate of ISR, stent thrombosis, stent fracture, perforation, TLR, and TVR. Of course, it's always in retrospect, but there is always a higher chance of atherosclerosis proximal to the bridge. So stenting prox LAD, want to make sure that the stent does not extend into the bridge, as that will cause problems down the road. The treatment is for bridge is, of course, medical therapy. Those patients who fail medical therapy do well with surgery on small series of surgical literature with surgical and roofing. If there's no disease in the LAD, bypass grafting to the LAD is not recommended, as especially the arterial graft will fail. But if there's disease already in the LAD with the bridge, bypass grafting is preferred. Thank you very much.
Thank you to the conference organizers. I'm truly pleased to be here today, taking part in 4TS. And for this session, we'll be covering stent failure, which I like to call a second chance to get it right. These are my disclosures. So we know that as stents have improved and the technologies improved from bare metal stents, the first generation DS, and then second generation DS, long-term major adverse cardiac events have continued to occur with reduced rates. However, with contemporary drug-eluting stents, despite improved technology, adverse events continue to accrue at reasonably high rates. And they continue even after the first year with MACE rates of about 2% per year. Now we know from contemporary US data from the NCDR registry, more than 10% of PCIs in the US are specifically for in-stent restenosis. We know that patients undergoing PCI for ISR have worse overall outcomes compared to patients without in-stent restenosis. However, even at centers that are using routine intravascular imaging is not routinely used for all cases of in-stent restenosis, as we see from this large single center registry. And this is so important because large-scale registries have also demonstrated that intravascular imaging significantly reduces long-term outcomes when treating patients with in-stent restenosis, as we see here from the IOPEN ISR registry out of the Washington Hospital Center. There was a significant associated reduction in adverse events when intravascular ultrasound was used, as opposed to cases that were angiographic guided. Now, it's important to understand, how do we define in-stent restenosis? And based on the original classification, which was based on bare metal stents, we described the different patterns of in-stent restenosis, largely based on whether it was focal or diffuse restenosis. We know, though, from pathology that there's many more different types of etiologies of in-stent restenosis beyond just focal and diffuse. When you really get into what the mechanism of restenosis is, we know from pathology slides, there's neointimal hyperplasia, we have neoatherosclerosis, which is a distinct process, and then, of course, a common process, which is stent under expansion. Fortunately, from intravascular imaging modalities, we don't have to rely just on pathology slides and autopsy. We can determine what that mechanism is in vivo using intravascular imaging. And with the intravascular imaging, in real time, you can recognize when a patient's ISR is primarily due to neointimal hyperplasia, if it's neoatherosclerosis, or stent under expansion. And we see here with representative examples, whether you're using intravascular ultrasound or optical coherence tomography, you can readily recognize each of these distinct modalities. We've introduced a new classification system that's based on this primary mechanism, because by recognizing the primary mechanism of stent failure, you can appropriately tailor treatment to try to overcome that stent failure and to try to improve the outcomes moving forward. So to put together the insights based on the different mechanisms of stent failure, we've introduced this algorithmic approach where treatment is really tailored to the primary type of in-stent restenosis. And as you see here, the different treatments differ based on what their primary mechanism is. So why does the intravascular imaging matter so much? Well, when we take a look at this angiogram, this is a patient who is referred for brachytherapy due to recurrent ISR. An angiogram, which is simply a luminogram, is two-dimensional. It's clear to tell that there is in-stent restenosis here, but it's impossible to tell what that primary etiology is. Is brachytherapy appropriate for this patient? I can't tell you that from the angiogram. So let's jump inside the vessel and see what's going on. When you look at the OCT, we see here in the middle cross-section the primary mechanism of in-stent restenosis or stent failure. It's actually severe underexpansion. There's a lumen area of 1.3 millimeters squared, where there's a distal reference that's greater than 9. You see multiple stent layers that are underexpanded in areas where there's concentric severe calcification, which is impeding those stents from adequately expanding. There's very little tissue here, and treating this patient with brachytherapy would be a grave disservice and do very little to improve their overall outcomes. Now, on the OCT longitudinal profile, you can clearly see where that stent under expansion is and how profound that is looking at the proximal and distal references. The best way to improve long-term outcomes for this patient is to do that root cause analysis, which we see is done nicely here with intravascular imaging, and appropriately treat that primary mechanism, which in this case is under expansion. Only then can we help to ensure that this patient is going to have improved long-term outcomes. So the take-home message, whenever encountering in-stent restenosis, is that all in-stent restenosis is not the same, and we should not treat them all the same. Now, of course, the best management would be prevention up front, which I believe we can do with routine and systematic use of intravascular imaging. And it's important to perform, when we are encountering in-stent restenosis, intravascular imaging prior to selecting the definitive treatment strategy and help identify what the mechanism is and number of layers of stents. Now, in all cases, you can't cross with an intravascular imaging catheter at baseline, and that's okay. It's just before applying the definitive therapy and implanting another layer of stent, it's important at that point that we perform intravascular imaging to really make sure we're understanding the situation. And then before that patient leaves the cath lab, at the end of the procedure, it's important to repeat the intravascular imaging and make sure you've achieved an adequate outcome, which includes adequate stent expansion. And that's going to be our best way to try to give these patients who we know are at increased risk of it, long-term major adverse cardiac events. And that's the best way we can help to reduce that risk of future target lesion revascularization by ensuring that we've achieved an acceptable result at the conclusion of the procedure. Thank you all for your attention, and hope you enjoy the rest of the conference.
Good evening, ladies and gentlemen. Let me start with thanking the organizers for inviting me to this August conference. Special thanks to Dr. Omar Khala. Today I'm going to present an unusual case of cutting balloon perforation. This case highlights the importance of keeping cool during a complex procedure if a complication happens, and also it signifies the importance of understanding the problem and then acting upon it. Let me start with the presentation of the patient. The patient presented with angina class 3 despite optimal medical management, optical medical therapy. The patient was a known case of 3-vessel disease with DES implanted in the LED D1 in August 2017 and August 2007. And this PCI was also done in the RCA in July 2017 and 2007. The LV function was widely reduced. The cardiovascular risk factors were hypertension, hyperlipidemia, and smoking. In the cornea angiogram, there was good result in the LED and RCA, but the LCA showed a 75% distal stenosis. This was a very distal lesion, and the vessel was just 2.5 millimeter. We had initially seen this lesion in 2017, but thought that this is a lesion which could be treated by optimal medical therapy. It does not have a prognostic value, and therefore we did not do it. We refrained from doing it. But since the patient presented with refractory angina, we decided to do it at this time. So let me show you the case. This is a 7 French EBU catheter, just the routine stuff there. And you can see in the distal L6, there is a high grade lesion here, 90% lesion. As I told you, this was a distal L6 lesion, but we treated it because the patient was patient was having refractory angina and was resistant to optimal medical therapy. So this is a run-through wire, a workhorse wire. Since this was a little calcified, we thought of dilating it with a cutting balloon. This is a 2.510 millimeter cutting balloon. After dilatation, you see an eccentric secular aneurysm kind of a thing. This is a situation just before perforation. Unfortunately, our wire got pulled back. We were intending to put in a covered stent because we were very, very sure it is a matter of time the vessel would perforate. So we were intending to put in a covered stent, but inadvertently the wire got pulled back. By the time we were reintroducing the wire, the perforation has already started here. Unfortunately, this perforation track had a very uncanny resemblance with a coronary artery. So we thought this is a vessel, and this is the true vessel. We forgot that this is a perforation track. Actually, we had never seen a perforation making a track like this, and we were taken aback. We thought this is the coronary artery, the right lumen. We put in the wire there, and this is the aneurysmal dilatation, which we initially saw. We thought it is there, and therefore we decided to put in a covered stent here. It completely struck off. It did not completely strike a mind that this is a perforation track and not a true vessel. But in the heat of the moment, we just forgot that. So this is a covered stent. The covered stent did not go easily. Obviously, this was going out of the vessel, so it did not pass through the vessel into the extra vessel space. So we had to take a guide liner, but even then we did not realize what is the problem and what wrong we are doing. So we dilated a covered stent, and mind you, this covered stent is out of the vessel. This is indeed a retrospective analysis. At that time, we thought, as I told you, we are in the true lumen. So the covered stent is implanted, and this is outside the vessel. We did a high pressure balloon dilatation, and to our bad luck and to this catastrophe had to happen. There is a through and through lumen which is communicating with the pericardial sac. So there is contrast freely flowing into the pericardium, a type 3 perforation there. So we occluded the vessel in order to seal the perforation, but it did not work. So this balloon is occluding the vessel. There is a second wire we passed in order to put in a coil there. So that we could, the idea was to put in a coil in the covered stent so that we could somehow occlude the perforation. So this is a coil implantation there in the perforation or in the covered stent, which was outside the vessel. It looked like the coil had worked to some extent. There was no perforation, but to our utter dismay and utter disappointment, there was this haziness in the left main. There was kind of thrombus or dissection. So we decided to stent the left main in continuation to the LED. This is a 3.5 16 Promus stent. And after, oh, I forgot to tell you, this was a Papyrus 2.5 15 covered stent. So coming back to this left main stent, this is a Promus 3.5 into 16 millimeter stent. After stenting, the left main LED ostium was fine, but unfortunately, this perforation started again. So what we decided was to put in a wire into the marginal artery and to exclude this LCX with a covered stent here. So we put in a wire in the marginal. As you can see here, the perforation is still continuing. There is pericardiocentesis being done. There is big tear in the pericardial space. So we put in after balloon dilatation. As you can see here, the perforation still continuing. So a covered stent there. This is again a 2.5 15 Papyrus covered stent. Then we did a kissing balloon dilatation with this covered stent balloon and a 3.5 high pressure balloon in the left main LED. After this kissing stent, the result was good. The LCX was totally cut off and obviously the perforation sealed. So this is how we saved the day. Next day, the pericardiocentesis could be stopped, the pigtail could be pulled out. There was, of course, a CK elevation of around 1200, troponin of 1600. There was an infarction in the LCX territory, but it was not a very large infarction. The patient was discharged hemodynamically stable and symptomatically and asymptomatic. So this is how finally we saved the day. So there were two covered stents, one in the perforation sac, in the perforation tract, and one in the left vein, and one in the LCX ostium, continuing into the marginal. So the take-home message is always confirm the wire position before dilating or putting in a stent, or before dilating or putting in a stent. When in doubt, refer to the initial pictures or the original angiogram. When a catastrophic complication does happen, ask for help with experienced colleagues and manage it in a cool and composed manner. This is very important. Besides experience in pericardiocentesis and complex PCI in general, a tertiary cath lab should have all the equipment to manage a perforation, namely coils and covered stents. Since there is some time left, I would give you a brief primer on the classification management of perforation. There are four kinds of classification, four kinds of perforation. Type 1 perforation is extraluminal crater without extravasation. So this is type 1 perforation. Type 2 perforation is a pericardial or myocardial brush without contrast jet extravasation. Type 3 is extravasation through a frank more than 1 millimeter perforation, as you can see here, perforation which is frank, and then a cavity spilling perforation into an anatomic cavity. This type of perforation does not lead to pericardial tamponade because the cavity is being connected to the perforation. So vessel is connected to the cavity. This is LED perforation draining into the left ventricle. Now, a word about management. Don't panic, don't hesitate in seeking help. No awards for being a Hercules in the cath lab. Volumes and isotopes should be given to maintain the hemodynamic imbalance which is there in the patient. Prolonged balloon inflation, sometimes all that is needed, but if tamponade develops, pericardiocentesis should be done. Covered stent, if they are deliverable, this may be an issue with distal lesions. Embolization are preferred if the lesions are distal, and embolizations, we do it with coils, but gel foam and thrombus could also be used. Platelet infusion, FFP direct into the coronary vessels have also been used, though we have never used that. We rely on covered stent and embolization only. Surgery and follow-up echo is very important. Thank you so much for your kind attention.
Hello. This is Dr. Mohammed Zaidan from Henry Ford Hospital, Detroit, Michigan. Today, I'm presenting to you a case of CTO-PCI complication. This is a 74-year-old gentleman with history of hypertension and diabetes. He had accelerating angina despite appropriate medical therapy with abnormal stress test and with inferior ischemia on an MPI and non-sustained VT on a Holter. A patient had a diagnostic angiogram that showed CTO of the RCA. He was referred for CTO PCI. This is his baseline angiogram. He didn't have any critical disease in the left system. He doesn't have really any clear epicardial or septal collaterals to the right. You can see it's a mid-RCA occlusion with ambiguous proximal cap with some right-to-right collaterals. See it here, a straight RAO of the RCA. So patient was referred for PCI of the RCA, CTO BCI. This is with a 2-guide injection, and you could see that there are no clear left to right collaterals. So initially, trial of antegrade wiring was done. This wire was outside of the vessel. So later on, we tried to go through septals. We did some septal surfing that they did not connect, and then some epicardial surfing from the LAD that did not connect also. We ended up going with an antegrade stick with IVUS guided antegrade stick, and we were in the true lumen confirmed with IVUS. So PCI was done to the RCA with 2 long overlapping stents with good result. You could see that there's some dye hanging. Initially, we thought it was from a septal, from the septal surfing that we did. We did a quick echo that showed some small pericardial effusion. Patient was hemodynamically stable. We took further pictures, and the bleeding was from an RV marginal. There was a wire in that marginal, and it seems that the wire did perforate the marginal around the curve. The wire was jade and could have avulsed the vessel in that area. So you could clearly see where the perforation is coming from into that RV marginal. So the decision is what to do with this perforation at this point, with the options, whether it's coiling, fat or thrombin injection, or covered stent, taking consideration that the patient, like the marginal was small to moderate size, it was a little bit distal and very tortuous. We thought delivering a covered stent may be a little bit challenging in that area. So the decision was to go ahead with thrombin injection. So this is over the wire balloon. When injecting through it, make sure that we're completely occlusive proximal so that the thrombin will not cause any problem to the main vessel. We injected thrombin here, and this is the picture. You could see that margin completely closed. So the perforation was sealed, but unfortunately, we had the patient on the table with a right heart cath in and also a 2D an echo. Shortly after we did the thrombin injection, the patient became hypotensive with the echo showing severe RV dysfunction and dilatation. We had a right heart cath in that showed a pulmonary artery pulsatility index of 1 with an RA pressure of 16, PA pressure of 24/12 with a mean 28, and a wedge pressure of 12, pointing to more toward RV failure. This is the echo was done on the table. You can see there is small to moderate effusion, but you could see clearly that the free wall of the RV is completely akinetic and the RV is dilated. So what to do here? Patient is in RV shock. How to manage that? Patient became hypotensive, requiring some pressors to keep his blood pressure up with accelerating doses. Decision was to go ahead and support the patient with RV support. we decided to proceed with 31 French protected tandem heart. After the support was put in, blood pressure normalized, patient was completely off pressors, back to normal. So patient was admitted to the ICU for weaning of the tandem and until the RV recovers. Almost 48 hours after patient was in the ICU, completely stable, suddenly he became very hypotensive. Repeat stat echo showed worsening effusion with signs of tamponade. Patient was emergently brought to the cath lab and emergent pericardiocentesis was done with improvement in hemodynamics. Repeat angiogram was done as we thought that the RV margin could have recanalized and could be bleeding. So this is the repeat angiogram. And you could see that the marginal is completely occluded in the mid segment, but there's some dye hanging in this area here. This is another view of it. And you could see that this dye hanging almost coming from this branch, from the conus branch, this collateral from the conus branch. We did further investigation where we went up with the wire and balloon in that conus branch. You could see clearly that there's that dye coming from this branch from the conus. We did inflate the balloon in the conus and we took another picture and we couldn't see any dye coming in from the marginal side. So we thought that the marginal was feeding through collaterals from that conus branch. So we went ahead actually and to isolate that collateral to the marginal, we put in a covered stent in that conus branch, closing that branch that's feeding the marginal. And you could see here after the covered stent put in the conus, you don't see that dye hanging anymore. Watch the patient, there was no recurrence of pericardial effusion, no more draining by the pericardial drain. The tandem was weaned successfully and then it was removed on day 3 after the tab was done. RV function completely recovered to normal on a repeat echo in 3 weeks, and patient was discharged home in a few days after. So points to take from this case: wire perforation can be very dramatic, especially when the wire is jade or a tortuous branch. This was a CTO, and the CTO went great, but it was the wire to protect that marginal that caused the problem. Thrombin injection is a tool to use for sealing perforations, but to make sure that the branches are small, will not cause any hemodynamic effects, and the thrombin is not injected in the main vessel. RV failure from acute marginal closure can result in RV shock. Pure RV support in these cases is very reasonable and can salvage the patient. And if you had a perforation and the patient is anticoagulated, perforation can bleed from a collateral, and this is what happened in this case. Thank you very much.
Well, it was a very exciting session and make our blood pressure to go up, actually.
Yeah.
Watching what happened in the cath lab. And but it was really very good cases and really a lot of learning from those cases. And the shared message with all of them is to keep calm and call for help immediately. And then almost always thing will goes well. So it's really very, very informative, and the complication case is the best, in my opinion, one of the best sessions we have, because we learn a lot from that one. And the classical, typical, simple intervention is kind of see it every day, but those complications we'll learn a lot from it. Now we'll open the floor for questions. If anybody want to discuss or have a question.
I think Dr. Zaidan's case, Dr. Zaidan's case was that last presentation, showed so many different things that could happen. It's that's a true educational piece, I think, for people around the world, don't you think?
Definitely. All the cases were really good. Dr. Zaidan have a very good case to patient have to be followed very closely because and be persistent. If we don't have answer why the perfusion coming back, we have to keep looking harder and harder.
Yes.
Actually, it was hard for me to see those collaterals from the screen here, but apparently they keep persistent and they found those collaterals. And when you find the problem, I guess fixing it is not as difficult as just finding sometimes. As was case, Dr. Jain have a really outstanding case, really complicated case. And I know during the cath lab, it's hard to kind of know, it's very easy retrospective to look at things and see, I wish I did differently. But when your blood pressure is up, your heart is beating hard and the patient is going away,
yeah, one question I had for Dr.
Very tough time, but at the end, the patient was safe in spite of very major complication happening in there. And also the case of those perforation of the bridging also is another interesting
Nice
case.
save, Dr. Jane. Thank you for sharing that case.
Thank you so much.
It's amazing. They always say it's not the first mistake, right? When things go south, it's usually the accumulate.
It more than anything, it reveals my stupidity.
No, actually, you know what?
Yeah.
Actually, the only one he will show the cases of complication. The one who is working a lot is doing a lot of cases, because the one who doesn't have any complication, usually they don't do any cases. So,
Absolutely.
Because if you don't want to, the best way to avoid complication, not do anything.
And that's how people learn, right? You can show a successful case, but then how to deal with complications.
Brave, yeah, it really to be brave to show cases, and that's really I think this is the brave people who present their cases, because that's the one we learn actually.
Actually,
Dr. Jane,
I reduce my guilt by showing these stupidities of mine. This is one way of
it was really the way things can happen wrong, but the smartness is to handle it on the spot, on time, and that's where make a quick decision, and make a quick decision. It can be the difference between life and death.
What I found out is, like, a lot of the time people get, if you are in a situation, you get into a tunnel vision and you focus on something. So it's always great to ask for someone from outside the room.
Absolutely.
To kind of, not even to scrub in, but take another look, because it comes with a new perspective and it can save you a lot, actually.
I think this is one thing I've learned is, even if you may have done 20,000 cases, doesn't matter, call somebody. He may have done just 10 cases, but still he could suggest you something. So never feel that there's somebody junior, somebody inexperienced. Always call for as many people as around could be really helpful.
Dr. Jane, I have a question about your case in particular.
Discussion answer, no?
Welcome, Dr. Fauzi. Dr. Fauzi is a cardiac surgeon here in Dubai. Matter of fact, he invented a technique called Dubai technique of repairing mitral valve regurgitation. Actually, it's his technique, and they call it Dubai technique. And he's been invited around the world to show his technique. And we are very pleased and delighted to have him with us today.
Thank you.
Okay, Annie, sorry.
Oh, that's okay. So my question, thank you, Dr. Fauzi. My question for Dr. Jane was, do you think that perforation, it was a perforation, do you think it went into some sinusoidal cavity, all these sinusoids that are there in the neonatal heart, right, that close off? Is that, because it looks so much like a vessel, right?
It does look like a vessel.
That's exactly. I'm trying to scratch my brain still. It has been now 3 or 4 months I had this complication. I still do not have an answer. How could a perforation track mimic so closely to a vessel?
Yes.
This is, and I must have done 25,000 cases till now, but I have never seen such a thing. Never.
Yeah, I think it was a sinusoid, and you were.
I think went to the vein, probably, and you are right. Probably went to the vein, and what we see really a blood vessel, and probably it was a vein. Yeah.
But what I don't understand is why would there be a tamponade if it went to a vein? It should have gone to cornea
Well,
sinus.
because connection between the artery and the vein, there is a small space that where the leaking was from. I mean, to reaching the vein went through the two walls, the arterial wall and the venous wall, and the bleeding was from that place. And it was confusing to see where to put. I mean, when the wire went through, kind of was really misleading. But it's really hard to figure it out during a cath lab. But retrospective, probably it went through the arterial wall to the space, pericardial space, then to the vein, and then you create a AV fistula there.
That's why we probably need 3D angiography now, right?
Yes,
It could as well be, yes.
As a surgeon, I can answer this question. I remember one case of perforation in NAD. It was a multi perforation, and when I repaired the case, it was an isolated RV perforation. So by transeptal, the RV was also perforated. So I did a matrix repair of the NAD and then Rima to NAD, but still I have to repair also the right ventricle in isolated area, a little bit, a few millimeter up. We face also a right ventricle perforation. It can happen.
So you mean through the LCX somehow the right ventricle perforated? That's what you mean?
Yes. So two sources of hematoma, because in fact some cover stent was done, but effectively also the indication was also for reperfusion, because if the intervention is not happy with also the what is the prognosis with the stent is risk of early thrombosis. Some interventions prefer to have a secured Rima to NAD even with the control of bleeding, especially in the territory of the NAD. So maybe in marginal, in some the artery of life, some intervention privilege the security with Rima to NAD. So one case, I repaired the Rima to NAD, and I see a perforation, of course, transeptum somewhere the wire go out, and the RV was.
So apparently the wire went from the LAD to from one of those septal arteries, and those septal artery went to the right ventricle.
Yes.
Probably that was the case. Yeah.
Yes.
Anyway, I have always an interesting question about the bridging. We've been doing quite a few CT angio now, and turned to be we see a lot of bridging. I thought this bridging was rare, but now I think about a third of people undergo CT angio. They have some kind of bridging, partial or complete bridging, short or long. And apparently we've been stenting bridging without even knowing it, actually. But most of those bridging probably partial bridging. Now for the complete intramural passage of the artery, probably that the one should not put a stent in there, because that's where all the complication will happen. But I don't know, I'd like to have the opinion of the panel here. It is very, very common to see stenosis, atherosclerosis at the edge of the bridging, the deep bridging.
Absolutely. Yep.
And how to deal with that one? I would like to have because it's hard really to put the stent right at the edge, because it probably also is not a good idea. So how you will handle those?
I find it challenging, especially in acutes like LAD acute, and then if there's a bridge, where to land the stent. And that's why I usually use IVUS to kind of precisely know where I need to stop my stent. And I try, if there's like an intramyocardial bridge, I try to avoid it at most with my stenting. I've seen like bad stent fractures, high risk of restenosis, high risk of stent thrombosis, and also, as what's shown in the case, perforation. The anatomy of the bridge is different. The area of the LAD is smaller than the the reference vessel distal or proximal to the bridge. Knowing there's a bridge, actually, there's a higher chance for atherosclerosis before the bridge. So there's a good chance you may find some obstructive lesion before a bridge, but I think imaging is key in those cases to avoid unnecessary extending the stent into the bridge.
Right.
Yep. One thing we have learned over the time is we don't stent the bridging area, but we do a drug-eluting balloon there.
Exactly. That's what I thought. We can agree with that one. Yes. Yeah.
And Dr. Halak, we have followed these patients. We have some 15 or 16 patients of this kind. And we have followed these patients, of course, not very systematically, and where we have not written a paper, but our whatever anecdotal experience is there, this is kind of effective. At least it mitigates the symptoms of the patients.
But that makes sense from mechanism.
And what we do is we take a long drug-eluting balloon, which is across the bridge area, so it lands into healthy area, proximal and distal, and we try to inflate it at a low pressure.
Yeah, I will always try to do a smaller balloon, because the things you don't want to have is dissection in that area, and you have to put a stent. So I will be kind of happy to have 50% residual stenosis, because and the patient will be fine, because 50% or less patient can be having no ischemia usually. So for those area, I agree with Dr. Jane. I usually put a smaller drug-eluting balloon, slightly undersized, and a low inflation pressure, to avoid any potential dissection, because if dissection happen, you stuck and end up with all potential complication.
Absolutely, Dr. Hell. I fully agree. I mean, there's to me, putting in a stent, because stent fracture, as Dr. Zaidan said, stent fracture is a veritable possibility, and best is to avoid a stent in that area. That is true. That is very true.
And all of you remember that, even like Dr. Halleck said, I think if you just settle for some stenosis, you can always send them for external counterpulsation.
Yeah. Yeah, actually, it's. I mean, sometimes we kind of seeing a beautiful result of stent. So of course, which is probably the way to go for I call it angioplasty. So we have a good angiogram picture. But when we use a balloon in peripheral or coronary, I think 50%, 30 to 50% residual stenosis, I think, is acceptable, as long as there is no big dissection. I don't know what the rest of the team will say.
And absolutely. And Dr. Halak, this is a critical point. If you reduce the stenosis from 90 to say 40%, angiographically it may not look good, but for the patient's symptoms, this is enough.
Right.
And therefore, the goal in these situations, in these particular situations, should not be to have a stent-like result, but even a residual stenosis of 25-30% is fine enough. That will improve the symptoms of the patient for sure.
Right.
At least that has been my experience. I don't know.
And second question is, for when you have perforation, and do you reverse anticoagulation while you are trying to seal the bleeding? Of course, hopefully it doesn't take that long.
It's
but
very good question.
What's your
that's
practice?
the dilemma. The worst thing to deal with is clot and perforation together. So
Exactly.
I don't reverse as long as I have gear in the vessel. And the problem with brotamine is you really don't know how the patient's going to react. And large bore sheath access like TAVR, they reverse all the time. But sometimes you don't know how brotamine is going to react with the patient. So I keep my ACT between, around 250. But as long as I have a wire in the vessel, I don't reverse, because the worst thing you're going to always end up with some thrombus formation with the acute platelet activation, all the bleeding that's happening, all those coagulation factors. So, try to control the bleeding. And if you need to reverse, you reverse after you take everything out.
Yeah, I agree with Dr. Zaidan. It's the same thing. The last thing you want to have to deal with is acutely thrombotic vessel in addition to a perforation. And fortunately now with papyrus and improved technology that we have available,
it's easier to quickly address the issue and try to, the best thing is balloon tamponading, then sealing the perforation and trying to get away without reversing.
I think there are two things I would like to add on this. One is I had a patient with left main perforation. I put in a stent, and after stenting, there was perforation. We gave protamine, and 10 minutes later, the left main was completely occluded. So protamine can occlude the stent or the vessels, the stented area particularly. But more important than that is it clots the blood in the pericardial space, and then you cannot aspirate this blood. And this is what happened with me. Once the pigtail was inside, I could see with echo, I could see with echo contrast that the pigtail is in the pericardial space. There was tamponade, but I could not aspirate. And then at autopsy, we found a complete layer of thrombus surrounding the heart. So for me, protamine is completely contraindicated. The second point I wanted to add was a lot of literature has shown that if you are very quick to stop the perforation, to seal the perforation and let tamponade not develop, then the mortality is virtually 0%. But once the tamponade develops, then the mortality is 50%. So I think that the curative action at that point to put in a covered stent or put in, don't wait for tamponade to develop. Don't wait for echo and see pericardial effusion is there or not. The best thing is to quickly stop the perforation. That is what I've learned over time.
Absolutely, absolutely. And I agree with the anticoagulation, reversing the anticoagulation. Perforation is a mechanical problem, need to have a mechanical fix, not a medical fix. So you have to have a mechanical fix because
and back,
medical fixes, yeah.
And back to Evan's great talk about ISR. Prepping vessel and calcified vessel, like imaging and calcified arteries, can save you a lot of grief with these big perforations, especially after you do a atherectomy up front and after. Make sure the vessel is prepped. You get better stent expansion, less ISR, and then less perforations when you crack that calcium up front.
Yep, and even just for vessel sizing, a lot of times the angiogram can be very misleading, and the intravascular imaging at baseline allows you to accurately size and help to reduce that risk. And then also, especially with diffuse disease, there's a lot of times very discordance with the lumen and the actual vessel size. So the intravascular imaging.
Absolutely, especially in diabetic. Evan, how often do you use imaging during intervention?
So it's standard of care in our hospital, which a little different from most of the U.S. We've taken on more of the Japanese kind of approach, where in our lab, uniformly we have 20 interventionalists, and it's used in 90% of interventions. We use both IVUS and OCT, but in our lab, OCT is the predominant modality, making up probably about 2/3 of the intravascular imaging cases here.
And the hospital administration didn't come to you on that one?
Fortunately, the chairman of cardiology is a big proponent of intravascular imaging, and under his guidance, it's become standard. And
because money for financial issue, yeah, of course, it can definitely improve the outcome, but sometimes kind of financial restriction on doing kind of semi-routine imaging.
Right. So,
of course, I agree with the left main for sure. You have to have image, and for, as you mentioned, in-stent restenosis, you have to have imaging. You have to find out what's going on. But otherwise, I don't know. I mean, of course, there is some really good indication, but I don't know. I mean, kind of there is a kind of balance between the cost and the cost benefit.
So it's a great point, and costs are the major question and limitation. So there's a major randomized controlled trial that just kicked off called the IMPROVE trial. So it's randomizing over 3,000 patients to IVUS versus angio-guided PCI. And one of the outcomes is specifically looking at the economic impact on this. And the goal, it's an international multi-center study, but the goal is to impact guidelines and reimbursement as well, if this ends up being a positive study. This specific study is exactly what you allude to. It's just complex lesions, though. So The first thing I think we need to prove economic utility in complex patients, and then I think down the line, all patients. The reason why we've made it standard of care, oftentimes you don't know it's a complex patient until you've done the intravascular imaging. You end up seeing that the lesion that looked focal on an angiogram is longer. It involves a bifurcation, oftentimes severe calcification. So, we always say here, it's not a type A lesion until the intravascular imaging shows that it is.
Well, probably sometime we have to use the imaging to avoid putting a stent.
Very often, exactly like Dr. Zaidan was saying, with the myocardial bridging particularly, you see with the intravascular imaging, it's not necessary. And very often we see from the intravascular imaging, also a lot of times it's diffuse disease. And if you could predict if it's moderate diffuse disease and you see you're going to get an inadequate angiographic result, you're going to have an inadequate result with PCI. Oftentimes we defer to aggressive medical therapy.
But I mean, the other point is you have to, I mean, how do you balance between physiology and anatomy? Because at the clinical outcome, it's more to support physiology, intracoronary physiology, than intracoronary imaging. I know there's some data to support intracoronary imaging, but I mean, not as strong as a physiology. What's your take on that one?
I think you need to integrate both. I don't think it's an either or. Yeah, so it's not either or. One of the things with physiology, for research, we've made it a binary dichotomous cut point. There's ischemia, there's non-ischemia. For FFR, we 0.80. For the resting indexes, we use 0.89. But ischemia is a continuum, and it's a big difference. If someone has an FFR of 0.81, that's very different than someone with an FFR of 0.99. And I think you have to evaluate the whole picture. And oftentimes when we have patients around the intermediate range or in the gray zone, we'll use intravascular imaging to help make a decision. Should it be medical therapy? Should it be PCI? Is there ruptured plaque and high-risk features, or is this stable lesions that could just be managed with medical therapy? And it's also important, to drive the pharmacotherapy, because a 0.82 and a 0.99 is very different. And that patient with a 0.82 needs aggressive risk factor modification and aggressive pharmacotherapy.
Absolutely. I think we have 1 minute here left, and we have Dr. Yasser joining us. He is a kind of expert of intracoronary physiology. So we have 1 minute, Yasser, to tell us about the importance of intracoronary physiology.
Thanks, Dr. Halak. Thanks for letting me in. I know I'm not a part of this session, but I saw my friend Evan, and because we work together in Columbia and CRF, so we have a very biased opinion, because we spend a lot of time doing research in this field. And you have seen during clinical practice as well that I think decision-making has to be guided by physiology. Angiogram itself is not good enough. It's a luminogram, and we're not doing justice by showing a 3D picture and just making a judgment by visual interpretation. And I know we, in a private practice in Dubai, the uptake is not great. And we do have data. Everyone knows that even in the best of the world, in US, I think it's 12%, 13% penetration. In Middle East, we don't have enough data, but yes, we need to do more, and that's what the message is. And it's so nice to see you, Evan, and thanks for accepting our request. And myself, Annie, and Dr. Halak, we are very grateful to you to participate. Yesterday, your talk was great on calcification. I know you spend a lot of time in Washington Heart as well, and we learned a lot from you, man.
Well, thank you so much for having it. It's truly great to be here. And I agree. It's great to have objective evidence. And that's really where physiology, when there is a borderline, when the patient's symptoms and the angiogram don't match up, it's great to have that objective data to help drive the best of decision making.
Yes, and
you are with Alan and Zayad there. Alan and Zayad, and of course, they are going to do every case imaging and physiology. And the uptake of imaging in Presbyterian, of course, they were doing more than 85%, and your dad is, I think, 100% now with OCT, yeah?
Yeah, pretty much.
One quick trick, Dr. Halak. If you want to do an angioplasty, Do an IVS. If you don't want to do an angioplasty, do IFR.
But with that one, we'll close the session. It was really great to have all of you here. I did learn a lot from this. I hope all my colleague, the participant, learned from this session. It was really good, and hopefully next year we'll have you here in Dubai physically and bring more cases. I don't want to have more complication, but things will happen and bring more. I think this is I always like this session because that's the one I learned the most. Thank you so much. Greatly appreciate it. Sorry that we have to move on to the next session.
Thank you so much.
Thank you.
Thank you all.
Thank you. Thank you so much.
All right, Dr. Omar, we are having a symposium coming up.
Okay, doc. So we have Dr. Osman Zubaidi.
So we would like to welcome you, and please give us your talk about cardiovascular health and managing NCD. Dr. Zubaidi.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. I hope all are in good health. Thank you for having me today, and thanks to the organizer for all the efforts behind the successful important conference. My name is Osman Zubaidi, and I am the medical manager for Gulf and Levant countries at Viatris. I'd like to take this opportunity to thank you all, our heroes, for all your efforts and dedication during the pandemic to keep us all safe. Thank you. Now, let me start by taking you across our Viatris story. I'm excited today to talk to you about Viatris, a new kind of healthcare company committed to providing access to medicines, advancing sustainable operations, developing innovative solutions, and leveraging our collective expertise to improve patient outcome. Viatris was created in 2020 through the combination of Mylan and Upjohn, a legacy division of Pfizer with headquarters in the US. At Viatris, we bring together best-in-class scientific, manufacturing, and distribution expertise with proven regulatory, medical, and commercial capabilities to deliver quality medicines to patients when and where they need them. Our branding reflects our drive to address the world's emerging healthcare needs with passion and compassion. It also highlights our goal to chart a new course focused on improving patient outcomes by expanding access to medicine, providing leadership through innovative solutions, and building best-in-class partnership. At Viatris, we see healthcare not as it is, but as it should be. We act courageously and are uniquely positioned to be a source of stability in a world of evolving healthcare needs. We empower people worldwide to live healthier at every stage of life. We do so via access, leadership, and partnership. Viatris is Latin for three paths. For us, those paths are our commitment to access, leadership, and partnership, which together work in harmony to empower people worldwide to live healthier at every stage of life. We have one of the strongest global commercial infrastructures in the industry, providing unparalleled reach across North America, Europe, and the Asia, Pacific, and emerging markets. Through our 4 business segments: developed markets, emerging markets, Greater China, Japan, Australia, and New Zealand, which is JANS, we are able to serve more than 60,000 customers in over 165 countries and territories. Our unique global platform comprises approximately 50 manufacturing sites across oral solid doses, injectables, complex dose formations, and active pharmaceutical ingredients, capable of producing more than 80 billion doses annually. Our global portfolio comprises more than 1,400 molecules across a broad range of major therapeutics areas spanning both non-communicable and infectious diseases, including best-in-class iconic brand names, as well as key brands, generics, including branded and complex generics, biosimilars, and over-the-counter offerings. At the heart of our work is quality. We are committed to ensuring quality across our global networks and in everything we do. So now, as you know the Viatris story, let me take you towards how we can together work together towards having cardiovascular health and managing the non-communicable diseases. So the main outline of my talk in this section is around the following 4 points. NCDs, which is non-communicable diseases, are silent killers, how the focus is skewed, need for person-centric approach, and the Viatris commitment. So let's start with the non-communicable diseases, which are called the silent killers. NCDs are, as I am sure I don't need to tell in detail, but just want to highlight that as per WHO definition of non-communicable diseases, also known as chronic diseases, tends to be of long duration and are of result of a combination of genetic, psychological, environmental, and behavioral factors. So NCDs scope in around 5 in 5, where the main types of NCDs are cardiovascular, chronic respiratory, such as chronic obstructive pulmonary disorders and asthma, cancer, diabetes, and now mental health and neurological conditions are well included. And within these 5 factors are that are identified, which are which have 5 risk factors, which is unhealthy diet, tobacco use, harmful use of alcohol, physical inactivity, and air pollution. So now NCDs are disproportionately affect people in low and middle income countries, where more than 3/4 of global NCDs deaths, that is approximately 31.4 million people, occur. Non-communicable diseases kill 41 million people each year, equivalent to 71% of the deaths globally. Each year, more than 15 million people die from NCD between the age of 30 to 69 years, comprising of 85% of these are premature deaths that occur in low and middle income countries. With this, $7 trillion are lost due to the cost of inaction, as compared to the $170 billion towards cost of action. So it means we need more action to be taken towards reducing the burden of NCDs in low to middle income countries. Now, this brings the count towards what is the burden within our region, Gulf and Levant countries, where we see that the NCDs account for approximately 77% of the deaths, of total overall deaths, out of the deaths of 118, which is total as per the WHO data from 2018. We can see from the breakdown, out of these total deaths, approximately 37% account for cardiovascular alone, and 14% for cancer, 3% for chronic respiratory diseases, 7% diabetes, followed by 17% for all other NCDs, 8% for communicable maternal and parental diseases, and 14% injuries. So now let's see the knowledge or skewed focus with patients on hypertension and dyslipidemia and how they are seen starting from awareness, screening, diagnosis, treatment, and adherence to the medication. So a case study was done to see how the hypertension patient journey can be mapped in light at different levels. We can see from this queue over an average duration of 3 months that approximately 600 million hypertensive patients were identified within emerging market, out of which around 270 million patients were found to be aware of their disease throughout. And out of these, approximately 100 million patients were treated for their disease. And when we reach the adherence part, we notice that approximately 15 million patients are controlled, which are aware of their adherence part. Now we will see the same type of case study that was done to see how the dyslipidemia patient journey can be mapped in light at different levels. And here as well, we can see that the skew over the average of 3 months that approximately 800 million patients with dyslipidemia in the emerging markets were identified, out of which around 480 million patients were found to be aware of their disease throughout, and out of these, approximately 100 million patients were treated. And from this, approximately 96 million patients out of 800 were controlled due to their adherence to the medication. So with this, we can see that there is so much that we can do together in having the patient educated and help them understand the awareness, treatment, and adherence to the medication in their cardiovascular health journey. So now let's see how we at Viatris see that for the need for person-centric approach rather than patient-centric approach. So at Viatris, we see the solution is towards an approach that is more person-centric, which is thinking beyond the pill solution for the patient, which is critical for improving healthcare outcome within our region. So our approach is under 5 different targets, which is towards awareness for public through our bringing health promotions, disease awareness, patient education, like the programs which we have, which is Dr. Adams videos, screening programs like Nurse Academy, where the nurses can be supported on disease screening and risk assessment. For physicians, we have an approach towards diagnosis and treatment decision through the programs like cardiovascular, global focus, global risk in focus, and Heal Portal, a scientific platform that is developed, designed, and specifically for our physicians, keeping them in mind. And lastly, for our pharmacists to help in adherence and compliance to medications through the online Pharmacist Academy. So if you can see, we at Viatris want to keep all the pillars covered to keep a strong balance with all our community. So to achieve this person-centric approach, we cannot achieve this alone and need to have a cross collaboration with intersectoral partnership between government, professionals and civil societies and business. And this can be done through defining partnership pillars around policy shaping, practice management, improvement, and patient outcome. And this cannot be achieved without our close work for the betterment of our healthcare outcome for our entire community together. So let me show you an example of one of the HCP portals that we have as a partner that we have developed, as a founding sponsor that we have developed with the partnership of American College of Cardiology, which is named NCD Academy. NCD Academy is an educational portal that is brought to you for the primary care community through the global thought leaders. a first of its kind partnership to equip providers at the front line of patient care with education available whenever, wherever, at no cost on fundamental skills for the prevention and basic management of major NCDs. The main feature of this academy is that it is an app-based program optimized for mobile use, as well as there is a desktop version via web browser and available for free worldwide and can be taken at any time, anywhere, and as well completed offline as well as per the user's own pace, covering the big 5 NCDs, mainly cardiovascular, cancer, respiratory, diabetes, and mental health. The NCD Academy partnership or collaboration structure is very clear, where we have the lead coordinator, which is the American College of Cardiology, having the founding sponsor as Viatris, and our global partners like World Heart Federation and NCD Alliance, which are formed globally. And locally, if you see that we have been multiple collaborations that have been done with multiple societies and Ministry of Health to bring this free to access to all our healthcare professionals. So now, as a Viatris, so with the aim or commitment by Viatris, at Viatris, we see healthcare not as it is, but as it should be. We act courageously and are uniquely positioned to source of stability in the world of evolving healthcare needs. We empower people worldwide to live healthier at every stage of life. We do so via access, leadership, and partnership. So we encourage you to stay connected with us on our website and social media channels. We are excited about the future as Viatris and the difference we can make for people around the world. So thank you so much for your time and looking forward to our collaboration to bring Viatris mission to life. Stay safe. Thank you so much.
Thank you, Dr. Zubaidi, for that wonderful talk. Dr. Omar, do you have any questions or comments?
It was really very nice presentation, and it was really good to know this is a new company, which is actually it's built on very strong companies before. So adding on more experience and the latest in the what's going on. So combining the legend of history and the excitement and the technology of the future that's put together. So it was really good, good presentation, and looking forward to have more educational program together.
Thank you for supporting our effort here. Now we're going to move on to another symposium, and that's Dr. Hani Sabur from Novartis, Emerging Therapeutic Options in Lipid Management, from Theory to Practice. Another very exciting talk coming up. Thank you. And I think, team, go ahead.
أهلا دكتور هاني.
Hello, how are you?
Alhamdulillah, أهلا وسهلا. Very nice to see you.
Thank you, sir. Is this are the slides visible or not yet?
Not yet.
Okay, let me try that. Should be like this. How about now?
We couldn't quite see them there. Let's try that one more time.
Okay. Here we go.
Just
okay.
Yes, we can see those.
Thank you very much. So thank you for inviting me to your stellar conference. As always, it's a very important learning experience for all of us. I'm going to come back and focus again on preventive therapies, and we're going to talk a little bit about LDL management with some emerging therapeutic options in lipid lowering and try to show some practical cases. So there's been a lot of advancement in therapies for lipid lowering. So we've always had the standard therapies, including statins and ezetimibe, which we've had for practically decades right now. The last 5 to 7 years have seen an expansion in the utilization of PCSK9 inhibitors, icosapentaenoic acid, and of course we have don't have access to bempedoic acid. But again, this is a very important additional therapy for treatment of patients with hyperlipidemia, particularly statin intolerant patients. Now, in the severe hyperlipidemia, homozygous FH, there is a role for lomitapide and mipomycin, and hopefully we'll have access to the anti-ANGPTL3 monoclonal antibody very soon. What's currently in the pipeline and very exciting are actually things like gene therapy, where it actually will create a normal LDL receptor, and this is a very early stage, and other modulators of ApoC and CRP. Now, in terms of lipoprotein A, this is gaining a lot of importance, and there's at least 2 different agents in the pipeline, phase 2 and 3 studies, that target the LPA gene messenger, so we actually can knock down the LPA quite efficiently. Now, right now, we only have in the therapies for RNA inhibition, inclisiran is the only approved LDL lowering therapy that works through RNA inhibition. I'm sure others will come through. So just a quick overview on LDL concentration. Now, we clearly know that LDL is the main target of atherosclerosis at this point. It is removed, cleared by the LDL receptor, which has very large numbers in the hepatocytes. They bind and remove the LDL into the bloodstream. And after the LDL receptor comes in, it's recirculated back to the cell surface in order to keep doing its job. So the faster it's recirculated, the more it can remove LDL and the more efficient the LDL lowering occurs. A key regulatory protein called PCSK9 actually blocks the return of the LDL to the cell surface. So more PCSK9, less LDL receptor, higher LDL. So we've discovered since the monoclonal antibodies that if you limit the action of the PCSK9 protein from using inhibition, or even better, prevent its production, you make the LDL receptor go much faster and remove much more LDL from the circulation. Now, one of the unique features about inclisiran is, as I'm sure you've heard, it's highly selective to the hepatocyte. It actually lasts in the liver cells and its effect on LDL inhibition is really lasting for months and months at a time. And I'm going to show you some real cases from our clinic. So what happens is that it targets the messenger RNA. So it does not go into the nucleus. It will not affect the genome at all. And it's conjugated with the special GalNAc ligand, which is this Y-shaped tail at the end of it, that allows it to be taken in high amounts by the hepatocytes. In fact, the plasma levels decline by 24 hours, and within 48 hours does not exist in the bloodstream. So the likelihood of off-target binding is essentially 0. So this also allows you to do 3 things. You prevent the production of the PCSK9 protein. There's a much greater and intense rapid uptake of the circulating LDL. And of course, this results in a tremendous lowering of the LDL levels in the bloodstream. Now, the mechanism is fascinating. And if you like molecular biology, you're going to find this unbelievable. So it basically goes in, is endocytosed into the cytoplasm. How do you prevent the actual chain from being destroyed? Well, actually, it loads itself onto what's called the risk complex. This actually removes the 2 strands. There's a guide strand, which completely mirror image matches the PCSK9 mRNA. So prevents the PCSK9 mRNA actually producing any protein. This is cleaved away. However, inclisiran still keeps going and going and going and going. So it continuously keeps reducing the PCSK9 production by preventing the protein, by preventing the mRNA from ever achieving protein synthesis.
Excuse me, Hani. I don't think. Are you moving the slide? Because I don't think the slides are moving.
Okay.
You only see one slide.
Which?
Are you moving? This number, I think, is number 4. We see only slide number 4. I don't know if you meant that way or you want more slides to show.
Trying to move the slides forward. It's interesting. All right.
Yeah.
Try this again. Okay. Stop sharing. And how about that? Okay.
We don't see any slides now.
Okay. Should be window and share. Okay. Thank you, Dr. Ahmad. Is this? Can you see slide? Can you see slide number?
I can see the slide. I think number 7.
7. Yes.
Yeah. Okay.
So
sorry to
no,
interrupt.
thank you for pointing that out. So I think these are really key points in the mechanism of action. It allows it to remain in the hepatocytes for a long period of time. It is very stable in the hepatocyte and only functions to inhibit the PCSK9 protein production itself. And a single inclisiran risk complex can cut up many PCSK9 RNA transcripts. So it's a very efficient way. Now, they have a very robust clinical trial program. We'll review some of these clinical trials. The long-term cardiovascular outcome study is called Orion 4. The others have already been published. They're essentially safety and efficacy studies looking particularly at LDL lowering. So we'll try to review the important clinical trials that have led to approval. They are about 3,500 patients over about 1.5 years in the pivotal studies. And they included 3 important groups of patients: heterozygous FH, ASCVD with CAD, CVD, and peripheral artery disease. And also in the Orion 11, which is more of a real-world study, it included ASCVD patients, plus diabetics, plus FH patients, plus patients with high cardiovascular risk. So basically the broad gamut of patients you would expect to see in your clinics. The idea of the studies, all 3, is basically the same. You inject the patient with the medication at day 1. Day 30 is the standard booster dose. 90 as the standard booster dose, and then every 180 days thereafter. So you have 1 more injection at 270 and 450. So basically 4 injections over 1.5 years. The endpoints are primarily driven by looking at safety and also at efficacy in LDL and protein, lipoproteins. So basically, if you look at these studies, and they're different populations, the heterozygous are obviously younger. They have a higher LDL to begin with. High intensity statin use is very good across the board. The use of ezetimibe clearly is higher in the heterozygous FH because of the understanding that you need dual combination therapy to get the job done. Now, whatever target population was utilized, you'll see here in essence, over 18 months, a very suppressed LDL in the order of 52 to 47%, less.
I don't think your slide are moving, Hani.
I don't know why that
We're
is.
still in slide 7.
That is very strange. Okay, let me try this. I don't know why that is. How about now, boss? This is the PowerPoint.
What slide do you want to be there?
So I'm actually on slide 20 right now.
No, it was. I mean, when you move it, actually it moved.
Okay, let me try one more time here.
No, it was. I mean, when you moved it, yeah, here you go. I think you are on 15, 16. Yeah.
All right. Quite odd. Okay. So as I was, can you see the slide this way?
Yeah, we can see it very well. Yeah.
Okay. So overall, if you took one of the studies, which was the main study that looked at ASCVD patients, for example, 52% reduction between the 2 groups over time at month 17, and a sustained reduction between month 3 and month 18. So basically, the implementation of the 4 injections produces a 54% reduction over 18 months, 4 injections. So this is very important because, of course, it is the long-term reduction of LDL that is key to this important cardiovascular reduction. The next slide, of course, now we're describing is what is the response depending on the subgroups, whether they are high body mass index, on statin, not on statin, high intensity statin, or any other lipid-lowering therapy. You do get this additional 54 to 50% reduction of LDL, which is very significant. Now, on this particular slide, I'm looking at the additional lipid parameters that are very important. And naturally, this agent targets PCSK9. We know that statins increase PCSK9. So you see on the right side, the placebo arm, there's an increase in the PCSK9 protein. There's a 65% reduction with inclisiran, and it's persistent from baseline to day 510. Non-HDL, ApoB, and very importantly, lipoprotein small a also comes down by 20%. So again, this is a multifactorial intervention that basically targets the LDL receptor function and improves it in a very significant way. So the side effect profile, and this is a very important concept on this slide, is essentially no different than placebo. In fact, the number of serious adverse events was higher in the placebo arm than in the inclisiran arm. And looking at all of the measured or mentioned side effects, arthralgia, bronchitis, diarrhea.
Dr. Haney, I'm so sorry. Can you change the slide without the full screen mode? I think that's what's happening.
Well, probably, maybe that's the problem, yeah.
Because we're not seeing that. It's such important data. We want to see it.
Sure.
Without full screen mode. That's
Is
what
this
they're
visible?
asking.
Is that okay?
Try to just change your slide for a second.
Okay. How about this?
I think you have to actually click on it instead of, probably just click on it. We're not seeing it now. I want everybody to see it. Sorry to interrupt.
No, thank you for, I don't know what's this very strange technical concept. Share screen. Okay, let's do this again. I apologize, really, this is.
Just do it manually.
Yeah, here we go. How about that?
Okay, good.
All right. So the adverse event rate is really no different than placebo, regardless of whatever you look at. The only difference is the injection site reaction, and that may be a mild pinprick or something at the site of reaction. But remember, this is only being done 4 times in 1.5 years. So in reality, nothing different than placebo. And as you look at the bigger clinical pictures, these are the extension trials, looking at patients with cardiovascular outcomes. That's the 15,000 patients with ASCVD, MI, and stroke. So if you consider, we have an 18-month, double-blind, randomized, placebo-controlled study with 4 injections over 1.5 years. And this is achieving LDL control 50% above high-intensity statin. So what is this actually doing? This is overcoming some important barriers in treatment of hyperlipidemia. Now, we define high-intensity statin as a statin that reduces the LDL by 50%. Is that right? However, you need to take 365 pills for the entire year to do that. The reality is patients forget pills, they don't go to the doctor, they don't get insurance, or some other problem. And in total, on average, only 26% reduction will result from the high-intensity statin if not taken every single day. The monoclonal antibodies are much better because it's 26 injections over the course of the year. But again, insurance barriers, we've seen delays, we've seen lack of visits. These patients get a 34% reduction rather than the expected true 50% reduction of biological effect. For inclisiran, this is the true benefit. It does not depend on the patient doing anything. They just come to your clinic, show up, get their injection, and for the next 6 months, their LDL is 50%. So this gives you the guaranteed 54% without having to do adherence, unless, of course, they don't show up for their 6-month visit, which is something you have to build into your schedules. So what's happening here is we are impacting the cumulative exposure through great intensity, which is what the monoclonal antibodies and inclisiran share together, but also a duration that does not rely on interruption or intermittent injections or therapies of other kinds. So what I tried to show you here is a few real cases from our clinic. So on the left is a typical patient. I hope you can see this slide because this is really a very visual slide here. On the left, you have a typical patient who has an LDL that starts fairly high and is gradually up titrated on statins, some ezetimibe, stops medication and goes back up again. So this very large area under the curve is essentially years of LDL uncontrolled multiplied by many years of poor control, meaning extra risk, extra atherosclerotic burden. On the right-hand side is a patient who's doing a little bit better. So this patient actually started on a high-intensity statin and continued to follow the program and has a much lower area under the curve. However, this patient's LDL target is actually supposed to be less than 1.4, so not reaching the target. And at the right end here, you can see, I hope, the reduction of LDL that is reached by the injection of a inclisiran. So you are reducing the area under the curve, therefore simultaneously impacting the LDL and the atherosclerotic burden. So the typical problem with the patient is what you see here. There is a target that's defined by the guidelines, less than 1.4. However, there's a lot of variability. So you start the patient on rosuvastatin, you give them separate ezetimibe, their LDL comes down, they stop taking it, you put them on the combination therapy, they're still not a target. You're still not reaching the target. And remember, the target is less than 1.4 in the very high-risk patient. So here's an example of one of our earliest patients. This is a very high-risk patient, a diabetic with LVH, with CKD, an ABI of 0.7, had a PCI back in 2019. So obviously, by all definitions, very high risk. So the European guideline would say that this patient has a target less than 1.4. Now, I went back in this patient's chart, and you can actually see the dots here all represent a single LDL reading. So going back 8 years, right at the beginning of this patient's journey, he had an LDL of around 5.7. Started on atorvastatin 20, probably wasn't taking it. A few years later, was put on atorvastatin 40, probably wasn't taking it. Over time, the LDL actually goes up. There's many things going into this discussion, worsening diabetes, weight gain, so on. Starts on atorvastatin ezetimibe shortly after their second, the start of the PCI in 2019. Now, what happens here is that the patient is referred to the cardiology clinic, the cardiometabolic clinic, and after a lot of discussions with the patient, we firmly told the patient, you have a target of 1.0, 1.4, you have to take your medications. So after that, the LDL goes down, gets a first dose of inclisiran, the LDL goes down tremendously, gets a booster dose at 90 days, and now we're suddenly at 1.0. So this is one of our earliest patients, has been on this medication for 9 months, gets their 180-day dose right here, and you'll see the average LDL now between these two lines is not only below 1, it's 0.39. Now, if you multiply 8 years by 4.7, that is the cumulative exposure for the last 8 years. What about the last 9 months? Can we continue the last 9 months' success and keep the LDL down with an injection every 6 months? Of course, the answer is yes. This is how this specific novel therapy works. And I'm going to just show you a little bit of detail on this other patient. This is not the same patient. It's another patient who was referred. And the patient had a starting LDL of 4.2. Now, I don't know if you can read the date here. It might be a little small. So this is one of our early patients, June 22nd, first injection of inclisiran. July 4th, and you can ask me, why did you do the blood test less than a week later? It was just a scheduling error, and 0.6. So you go from 4.2 to 3 to 0.6. So there's an intensity that's very equivalent to all PCSK9 inhibitors on top of high-intensity statin, but the additional benefit is duration. And if I come back to this issue of variability in response, this is another patient. I mean, these graphs are remarkable, aren't they? Over the course of time, you see the LDL shooting up and coming down, shooting up and coming down. This is a patient with recurrent ASCVD, diabetes, multiple stents, a target LDL of 1.0, only reaches that twice in an 8-year course.
Dr. Hani, 1 minute, please.
Yeah,
One
sure.
minute. Just
We're
1
just
minute. Yes.
So as it is, I think the key point is you can eliminate the variability that comes from insurance issues, compliance issues, not taking my medication issues, not taking my pills, and allowing the patient to achieve the target LDL with a very persistent over time, with a simple solution that comes to your office and brings the LDL down, and therefore has a proportionate reduction of cardiovascular risk. And with that, I thank you very much for your time and your patience with the technical errors. And if you have some questions, I'm happy to do that as well.
That was awesome. Awesome. I'm sure we have a lot of questions, and we will have some time to ask those questions, but I think we have to go further into the ACS intervention segment. Is that right, Dr. Halak?
Yeah, we kind of slightly running a bit late.
Yeah.
It was a really nice talk, and definitely this is a new medication, make it very convenient for the patient, and as you said, it really improved the compliance. And appreciate your presentation, was really very nice. I'm sorry that there's some technical issue we have through, but at the end it was really good. Thank you so much, greatly appreciate it. Thank you.
Both of you, thank you so much for teaching us during this session. And we have to go forward to ACS intervention, right?
Please do.
All right. Thank you, gentlemen. All right, we have a host of presenters coming up, including Dr. Omar Latif from USA, Dr. Al-Reyes from USA, Dr. Kiwan, my friend from UAE, Dr. Abdul Majid Al-Zubaidi, another friend from UAE, Dr. Suresh from the USA, and Dr. Shahab, my friend, and Dr. Tafur from the USA. So lots of gentlemen coming up to teach us about acute coronary syndrome. And we'll start now with Dr. Latif. Team, you can start the videos.
Good day. I'm honored and delighted to be with you today and to speak about mechanical circulatory support in cardiogenic shock. I have no conflict of interest to declare. The problem with cardiogenic shock and cardiorespiratory failure is that it has a very high mortality rate. For out of hospital cardiac arrests, the mortality rate is nearly 90%. And for in-hospital mortality rate for patients who have cardiac arrest, the mortality rate is about 75%. So the outlook for such patients is really dismal, utilizing pulmonary support or closed chest CPR. Trials have shown, such as the CESAR trial on patients who had respiratory failure secondary to the influenza pandemic in 2009. Those who received conventional treatment fared much worse than those patients who received extracorporeal membrane oxygenation. Furthermore, the ARREST trial, in which patients who had out of hospital cardiac arrest, those who received the traditional support, only 7% of those survived, while those who received extracorporeal membrane support, 43% of such patients survived. This data has led the American Heart Association to make a statement in 2021 that extracorporeal support should be available and used for patients who sustain a cardiac arrest and are not regaining their spontaneous rhythm. What are the devices that are available for mechanical circulatory support? Historically, there have been a number of devices. The intra-aortic balloon pump is the longest standing device that has been used. Its value for supporting patients who are in severe cardiogenic shock is really very, very poor. It has not been proven to be of great effect. Its use currently is limited to patients who have chest pain or patients who undergo cardiac surgical procedures and they require mild to moderate support. The value of intra-aortic balloon pump in such cases is of benefit. Impella is practically replacing the intra-aortic balloon pump in the cardiology field because its effectiveness and its value has been shown to be significantly better than the intra-aortic balloon pump. The tandem heart is mentioned here just for historical reasons. I don't believe there is much use for the tandem heart, which is inserted transvenous percutaneously and across the interatrial septum, aspirating blood from the left atrium and pumping it into the arterial circulation. Again, tandem heart is not used much at all these days. The most powerful system that is used is the veno-arterial extracorporeal membrane oxygenator, and this device is used by inserting cannulas into the venous system, another one into the arterial system, and run through an external system where there is a membrane oxygenator and a pump to allow circulation of the venous blood across the membrane and push it back into the arterial system. It is an expensive device. It requires constant monitoring. It consumes a lot of resources because you have to have a perfusionist or highly qualified nurses who manage that with the risk of bleeding is not consequential. So this device is very powerful, very useful, and its use is best applied when there is biventricular failure. In my institution, we are launching a shock team. We have a stroke team, which has been operational for many years. When a patient has a stroke, we call for a stroke consult, and immediately a stroke team will come and evaluate the patient and take them for a CT angiogram of the cerebral circulation and possibly take them to the intervention lab and aspirate clots if it is identified. The pulmonary embolus response team is another team that over the last 6 to 7 years has matured in our hospital and across the United States and perhaps elsewhere, where patients who sustain a massive or submassive pulmonary embolus, they are evaluated by a PERT team, which is usually made of pulmonologists, emergency room docs, intensive care docs, cardiac surgeons, cardiologists, and a joint decision is made on whether to treat patient with anticoagulation, thrombolytic therapy, interventional therapy, or surgical intervention. The shock team now is coming online, and in my institution, Dr. Matthew Tommy and I are chairing our team in the building the shock team. And here are the parameters that we use to identify patients who may require the shock team management. So patients who come in with inability to maintain blood pressure greater than 90 millimeters of mercury without intravenous vasoactive agents or mechanical support system, patients who have hypoperfusion with evidence of poor end organ effusion, patients who have lactate greater than 2 or who are in respiratory failure, and we suspect a cardiac-related problem. So these are not septic patients, not hemorrhagic patients. If any patient who meets such criteria will be evaluated and seen, and immediately a shock alert is sent out, perhaps through a WhatsApp or something similar to the entire team, and I will share with you who the entire team is. So a notice is sent out, and further evaluation of such patient is carried out. And if this patient has a STEMI, then a code STEMI is initiated, and the cardiologist and the intensivist become involved, and the patient will be mobilized to the cath lab for further intervention. If the patient's condition warrants at this stage, a decision to activate the shock team is made, and a multidisciplinary team is activated, and a plan is made to move forward with the appropriate device. Who are the members of the shock team? The members are as follows: the cardiac intensive care cardiology fellow, cardiology attending, interventional cardiology attending of the day, the advanced heart failure attending, the cardiac surgery attending, cardiac anesthesia attending, medical intensive care unit attending, the perfusion services, nursing leadership in the intensive care unit, the cath lab leadership, and the opera room nursing leadership. So this will show you that if you are going to have a shock team in your institution, you need to prepare in advance, assemble your team, alert everybody to this process, so that once you send a signal, certainly the first signal, everybody will be on alert and they will start preparing the necessary requirements. And if the activation signal comes out, then the team will meet and discuss which device to use. And for an extra corporeal support or intracorporeal support, the decision typically will be a device like an Impella or an ECMO. So in conclusion, I would say that cardiogenic shock remains lethal. Early intervention when indicated is life-saving. Mechanical circulatory support applications are growing, and the shock team concept is catching hold across many centers in the United States. This eCPR, as it is often referred to, is protocol-driven and deserves your full attention. Thank you for your attention to my talk, and I'll be happy to discuss it in further detail and hear from you again. Thank you so much. Goodbye.
All right, thank you again for having me today on a 4TS meeting. And my name is Shad Reyes. I'm from Medical Director of the Cath Lab and Cardiac Rehab at Detroit Medical Center, Assistant Professor of Medicine at Wayne State University, and Director of the Interventional Cardiology Research. I was asked to talk about the acute myocardial infarction with large clot burden, and this is a case-based discussion, so as much engagement as possible from the audience. And again, thank you for the organizer, Dr. Halak, and his team for inviting me. Let's start with the case. This is a 54-year-old presented with chest pain, ST elevation, as you can see there in the anterior leads, as well as reciprocal changes in the inferior leads, suggesting LAD disease. So the patient emergently brought to the cath lab. RCA was okay. We tried the radial access, but because of his severe spasm, we weren't able to get the radial access. Otherwise, the standard in our labs to go radial with 70% of our cases done radially from STEMI. You can see thrombotic lesion proximally. We tried to balloon angioplasty, but it was heavy thrombus. Despite giving the patient therapeutic ACT with heparin above, with ACT above 250, we gave him also a tirofiban, which is a 2B3 inhibitor for a heavy clot burden. Eventually, we were able to do thrombectomy with the Penumbra Cat RX, which is our standard thrombectomy catheter, as you can see there on the left side. And eventually, we were able to explant or take out the heavy clot burden. And eventually, we were able to do balloon angioplasty with two-wire technique in the circumflex to prevent any clot dislodgement or into the right side, into the circumflex. With deployment, IVUS guided measurement of sizing, and eventually good apposition with IVUS post PCI, as we dictated by the current ultimate trial, suggesting post PCI IVUS associated with better outcome angiographically as well as for TVL. So again, patient did well. Ejection fraction was 30%. Stunned myocardium, started on guideline therapy. Ejection fraction was low, so ended up with live vest as well. We'll move on to the next case. And again, I'm here not advocating for routine thrombectomy for these cases, but these are heavy thrombus cases. So the majority of the cases I'm presenting are related to thrombectomy was performed. And therefore, I just want to make sure that you are aware that routine thrombectomy is prohibited by the guidelines. 48-year-old female presented with chest pain and ingestion, started at 4 a.m. this morning, in the morning of the presentation. And these are the EKG changes, as you can see there. Again, you see heavy thrombus, and this is very organized and very delineated by the angiogram with the dye hang up in the proximal circumflex. And in this case, for example, we went straight after we tried to balloon, but because of the RCA dominance and the wired position, we did thrombectomy right away before performing any balloon angioplasty to make sure we're preventing any distal embolization. And indeed, we did a thrombectomy here with a heavy thrombus removed, and without any ballooning or anything, you can tell there the perfusion is perfect. And this is how for example, the penumbra system work. And again, we are using a different system in different labs, but this is what we are using here. It's a 6 French system. It's over-the-wire rapid exchange. You put it in the 6 French, and eventually you don't turn suctioning till you are engaged with the thrombus. When you are engaged, you turn on the thrombus, the suctioning system, which is done by the operator at the back of the table. It's the sterile system. When you are done with thrombectomy, you eventually you pull the system, staying on negative pressure all the way. You come out from the TUI or from the co-pilot, whatever system you're using for delivery. And eventually from there, you do balloon angioplasty and stenting as needed. Again, this is a stent deployed, and this is the final result showing complete resolution of the 100 improvement of TIMI flow from 0 to 3. Again, moving to the next case, this is a 65-year-old, 10 minutes chest pain prior to arrival. Patient reported chest pain is substernal classic. He has multiple comorbidities. Again, you can see here in the caudal view or in the spider view, the circumflex smile disease, and then there's a large OM1, or if you could call it a ramus intermedius, and there's it's 100% inclusion of the LAD with dye hang up and TIMI flow. This is the patient had a stent recently at an outside institution, and he came because we thought maybe he's not complying with his medication. Again, heavy thrombus, balloon angioplasty didn't do it, so we ended up doing thrombectomy again in this case with a big clot burden and a 2020 balloon, and then we were able to give we gave a bolus of tirofiban, which is our 2B3 inhibitor in our lab, and started in the drip in the case despite ICT therapeutic. IVUS guided, showed no residual clot, and eventually stented with a 3.5 by 28 stenting. This is the IVUS on the left side. The left two images are showing that the layering as well as the thrombus present in the area from 4 o'clock all the way to 11 o'clock in the stent, and this is after thrombectomy and balloon angioplasty of the stent. Moving along to the next case, this is a STEMI with occlusive iliac, a 56-year-old presented with multiple comorbidities and multiple stents in the past, and low ejection fraction ICD, presented with cardiogenic shock and low blood pressure requiring levofed as well as dopamine. ST elevation AVR as well as diffuse ST elevation in the lateral lead. Indeed, RCA is completely occluded with CTO, but on the left side, circumflex has a 90% disease, hazy thrombotic lesion, as well as in the ostial LAD, suggesting thrombus and the LAD as well. So both, because of these metrics, the patient was kind of stable. We did perform Swan-Ganz catheter that came suggesting a scarring index of 1.2, CPO of 0.23, and the cutoff is 0.6, as we know, and PAVI 0.9, the cutoff is 1 as well. So just suggesting this is a purely LV dysfunction or failure in the setting of acute cardiogenic shock. Again, the iliacs were not favorable. Again, very hostile, calcified. He has a fresh stent in the left iliac as well as a severely calcified lesion on the right iliac. What we ended up doing is ballooning with shockwave because alternative access was not an option, as well as because of his body habitus, as well as because of the arm intubation and too much equipment, but also transcable is not an option because there's no requiring CT scan and evaluation, and due to also experience as well, requiring centers with high experience. However, the shockwave becoming favorable in these cases, emergent cases, where you can size it 1-to-1. In this case was a big iliac, so we cited 7.0 by 60 standard balloon length, and shockwave at 4 atmospheres, and then multiple times, and eventually you can see how the opening and yielding of the lesion in these cases after multiple shock deliveries. And this is how the system works. It's inflated at 4 atmospheres. You pulse 30 pulses per treatment for as many as you want. It comes loaded with a 180 pulses and therapies, and then you can inflate at 60 once you are done with lithotripsy. You can inflate at 6 atmospheres when you for nominal pressure, and then as you see there, the right groin is getting accessed smoothly by the Impella sheath, which is 14 French in this case. Impella inserted, the patient hemodynamic improved. Again, balloon angioplasty and stenting was done after receiving tirofiban as well as heparin anticoagulation and the TIMI 3 flow. Again, you can see the LV is not squeezing the way it should be. It's very weak. His baseline 30, but this is definitely less. So the patient eventually transferred to the ICU, and from there stayed for 2 days for weaning. And then I already gave a talk about weaning. I think you're going to see it either today or tomorrow on the program, but there's a weaning protocol that we follow. But the patient was weaned in the ICU, was favorable. Then we went back to P9 on the Impella, brought back again the next day. We did another weaning trial in the lab, and eventually we explanted the balloon, the Impella, and he discharged or the ejection fraction 40%. Moving to the next case, 68-year-old ST elevation, as you can see in the anterior leads. However, as I mentioned earlier, we are 70% radial for all our STEMI cases. So a kind of very advocate for radial access. So again, this is was severe spasm. Patent is fine, no perforation, but again, it was severe spasm. So you have two options here. You give more medication, more sedation for these cases. Verapamil is our go-to after the nitroglycerin, more sedation for sure, and or you move to a more mechanical method in delivering these the guide. Either you do catheter assist tracking or balloon assist tracking. The guy, I mean, we even sometimes with a woolly wire, sometimes you can navigate, but again, you are at risk for injuring the endothelium of the radial artery. So in this case, for example, we used a 4 French guide, 125. It has to be longer than the guide apparently, and it sticks out of the guide, and you can make a nice transition from 6 to 4 French, make it a little bit smooth and track easily into the subclavian. The other technique that has been described before by Pancioli and others is balloon tracking, where you got 6 French guide, that means a 2 millimeter diameter, then you put 2 0/20 balloon, half and half within the tip at the tip of the guide, and eventually you inflate it over an 0.4 wire at atmosphere, and eventually, as you see there, you can both move them over the 0.4 wire balloon tracking or BAT all the way to the ascending aorta. From there, you engage. Again, this is an anterior STEMI, so the patient was engaged successfully, and eventually 2B3 inhibitor was given. Thrombectomy was performed again because of heavy thrombus and TIMI1 flow after balloon angioplasty, and because of showering distally, it developed some no reflow that ended up with some distal embolization requiring nicardipine as well as adenosine for distal flow improvement, beside high improvement. So again, here we did balloon angioplasty. However, it's very severely calcified. We were not. I wouldn't deploy a stent over this calcium. So we wanted something to do atherectomy on during that case. However, during these cases, which is hostile and fresh STEMI, a recommendation is to stay away or refrain from the orbital atherectomy or rotational atherectomy, although there is no evidence, but majority of the operator don't feel comfortable doing after thrombectomy and opening a vessel to do that. One option was, I mean, I posted that on social media, is to do a laser atherectomy. That's one option, or you do shockwave. So what I did in this case, we did balloon angioplasty, there's TIMI 3 flow. So I kept the patient with a radial sheath, disengaged, and brought him to the cath lab the next day after being on drip of 2B3 inhibitor overnight. Brought him back, TIMI 3 again, but not ideal vessel, as you can see here. So we did a shock wave in this case, and then eventually, which is F3O and coming 4O as well, 3.5 and 4O. Balloon angioplasty, shock wave, and eventually IVUS, and then balloon stenting in the LAD, as you can there, from ostial all the way to the mid. Successful deployment and good yielding, suggesting we were able to fracture all that media of the LAD as well. And final results showing TIMI 3 flow and resolution of stenosis from 100% to 0%. With that, I would like to thank again the organizer for inviting me for this conference, and please, I will be happy to take any questions after the meeting. Thank you again for having me. This is Shadi Reyes from Detroit Medical Center.
Oh, hello, this is Dr. Yahya Kiwan. I would like to thank Dr. Omar Hallaq for giving me the 7th time opportunity to present in the 4TS. Today I'll talk about the drug-coated balloons, DCP in primary angioplasty. Now, what are the rationale of using drug-coated balloon in primary angioplasty? Now, we know that if you comparing balloon angioplasty in the stenting trial, has shown only a stent has a reduction of the TVR, but no effect on mortality or reinfarction. Number one, the rate of stent thrombosis is still high, ranging between 1% to 2%, and there is a late stent thrombosis up to 5 years. There is usually, when you do primary angioplasty, it is very difficult to find the full details of the patient history. For example, we don't know the patient is a high-risk bleeder. We don't know whether he needs a long-term anticoagulation. We don't know whether he might need a surgical procedure, and we don't know whether he's compliant for dual antiplatelet therapy. Now, and also, if you find a diffuse disease in a primary angioplasty, the target lesion revascularization rate is really high, up to 28% restenosis. That's why people thought DCP might be a good alternative to treat diffuse lesions. These are the stents, the balloons, the drug-coated balloons available in the market. Most of them paclitaxel, and only 3 are sirolimus. Now, I just review the current literature about the clinical trial of DCP for treatment of STEMI. As you could see, there are about 8 or 9 randomized controlled trials. The primary endpoint is either late lesion loss or cardiac death, but the secondary endpoint mainly is MACE, which is cardiac death, MI, and TVR, and almost similar in the MACE, similar in the most of the trials. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9 trials. So I choose 1 trials only because of short of time. And this is called a Revelation trial. This is the biggest trial in DCP in primary PCI, comparing paclitaxel coated balloon versus drug-eluting stenting in acute MI. Well, the results of this trial showed in a total of 120 patients were included, a 9-month follow-up enrollment. The FFR is the same in the 2 group, and only 2 patients require non-urgent TLR, 1 in each group. The conclusion of Revelation and STEMI DCP strategy was non-inferior to DES. There is no significant difference in late lumen loss, and the MACE outcome was similar between the 2 groups. And the DCP seemed to be a safe and a feasible strategy. What technical recommendations for DCP in primary PCI? Aspiration thrombectomy always needed to deliver the drug on the balloon. There is a mandatory pre-dilatation, and the size of the balloon 0.8 to 1 at a nominal 6 to 8 atmosphere. There is a liberal use of nitrate, liberal use of 2B3A to clean any thrombus, and no need for stenting unless type C dissections occur. So if dissection of less than type C, and if TIMI flow is 3, and if no more than 30% residual stenosis, then you consider drug-coated balloon instead of stenting. The DCP diameter should be the same diameter of the largest balloon used for pre-dilatation. DCB should be used only for drug delivery, not for further dilatation. Of course, when inserting the DCP, you have to avoid any friction in the Y connector, and only, as we said, type C dissection occur after DCP, then DES rather than bare metal stent is used. And the type of DES is irrelevant. What type of drug on the stent, it doesn't matter whether similar or different from the coated balloon. What are the key points to remember in primary PCI with drug-coated balloon? We know primary angioplasty. These are the literature I'm reviewing. And primary balloon angioplasty is superior to thrombolytic therapy, decreasing mortality and re-MI. These are facts. However, if you take the trials of balloon, bare metal stent compared to balloon angioplasty, we were reducing the target vessel revascularization only, the TVR. There is no effect of stent over balloon on the death or MI. These are the facts which we need to remember. Again, when we're using bare metal stent compared to thrombolytic, we are reducing TVR. So stent better than thrombolytic, but the bare metal stent and the drug-eluting stent, they are the same of having lower TVR, but similar. Now, in a review in the literature by Brody, more than 2,000 patients, a review of angioplasty over 10 years, showed that target vessel MI and stent thrombosis or lesion thrombosis was significantly higher with both BMS and DS compared to balloon angioplasty. So he showed here balloon is better in this matter. Now, although stent implantation is often considered as definitive treatment for primary PCI, the aim is by skewering the vessel lumen. This may not provide optimal long-term outcome always. So DCP-only strategy has recently emerged. In a review of more than 253 cases presented in the Euro PCR, what they found that acute vessel closure requiring bailout stenting was only less than 1%. And the overall bailout over 30 days was 9%. Mortality was low of 2%, 1 year mortality of 6%, 1 year MI of 2.6%, and TLR is 3%. It's really low by doing drug-coated balloon angioplasty. So what are the limitations of DCP technology in acute myocardial infarction? DCP are associated with increased risk. There is a persistent residual stenosis. That's an issue, and the presence of dissections. Now, DCP require very optimal lesion preparation before using the drug-coated balloon, and DES is better than coated balloon in terms of restenosis. Now, limitation of the trials of the DCP trial. The number of patients included, they are not relatively small. The follow-up period was relatively short, maximum was 12 months. And most of the study were randomized control, but only one of the study was multi-center study. And the other issue, they use only paclitaxel stent, a balloon, but the trial did not use sirolimus-coated balloon. In conclusion, stenting remained the standard reperfusion strategy in most settings of AMI. However, in-stent restenosis, stent thrombosis, and reinfarction present challenges. DCP represent a safe and effective method for the treatment of in-stent restenosis, small vessel disease, and a promising strategy in case of acute myocardial infarction. However, we need a long-term follow-up to determine a long-term benefit of DCP compared with those of new generation of DES. Thank you very much.
Welcome, Dr. Al-Zubaidi.
Thank you, Annie. Can you hear me?
Yes, we can. Go ahead.
Thank you. So thanks again to you. Thanks to Dr. Halak for the invitation. And with you, Abdul Majid Zubaidi, I'm a cardiologist practicing here in Abu Dhabi and at SSMC. The case, so I was asked to present a case, and interestingly, I got two cases that have similar theme, and you will see this over the next few slides. Most of the case is going to be images, and it shows a STEMI cases that presents with two culprit lesions. So the first case is a 40-year-old smoker and a bodybuilder who's on monthly anabolic steroids, and he was brought to the emergency department with 4-hour history of compressive chest pain. He does not have any other risk factors. And his physical examination, as you can see, he's tachycardic with borderline blood pressure, killer class 3. So he started to get congested, and this is his ECG. And obviously, he got an anterior ST elevation. Also, he got something suspicious in the inferior leads, as you can see, where there's a subtle ST elevations involving the inferior leads. So there's an anterior and inferior ST changes. So this is his angiogram, and you can see, initially we thought mostly this is going to be an anterior from the ECG because the changes in the inferior leads were very subtle. So we picked the right diagnostic catheter, we go radio, and we looked at right diagnostic to just look at the right and then go with the guide to the left coronary. So going to the left coronary, we were not able to see much. I mean, obviously there's a cert. This is it looks like an ramus, but the LED looked almost occluded from the ostium, so there's a flash occlusion. Now, if you look at the second segment, you start seeing some hanging contrast where the LED up, on the screen here, you can see the 12 o'clock, and you can see some hanging contrast there, indicating maybe there's something there that is occluded, and most likely it is acute because the hanging contrast. So we took a cranial shot, and obviously you see the proximal part of the LED now here. And this view is more clear as compared to the previous one where there was an overlap. So the LED here is obvious, and there is an acute occluded LED. So which one is the culprit? Is it the LED or is it the RCA? And we were puzzled because they both looked fresh lesions. So we said, let's go after the RCA first, and obviously there is what looks like a heavy thrombus extending all the way from the proximal to the mid segment of the RCA. We don't use aspiration thrombectomy as we heard from the previous talk routinely, but occasionally, it's according to the case. And if we see a very large and a very large burden of a thrombus, then we use the aspiration thrombectomy. And sometimes we're lucky, like this case, where we got a good chunk of the thrombus out. Still, there's a residual thrombi there, but definitely the thrombus burden was reduced. And as you can see, the flow here is not bad. Still, I mean, it's not the optimal flow you would like to see, but definitely it is better compared to when we started. So we went ahead and implanted a stent, and they, we sometimes in such a heavy thrombus, we don't post-dilate the stent, we kind of leave it, and we come back later on and post-dilate it and get an optimal result, just to avoid squeezing thrombi distally and avoid distal embolization. So for this patient, we stopped there, we got a flow, and we thought of going back and attempt the LAD. And so you can see here, on the previous view, it wasn't easy to wire that LAD, but finally we were able to, to wire it and balloon it. And again, there's another thrombotic lesion that is the culprit for total LAD occlusion. This lesion doesn't look chronic. This lesion looks like an acute occlusion. As you can see, there's a filling defect there, indicating a thrombosis and a thrombotic occlusion. This lesion was again stented, and we achieved a good result with the TIMI 3 flow. So two culprits in one patient who's a smoker, bodybuilder with anabolic steroids. The second case again is a young chap. As you can see, I mean, a lot of our STEMI cases occurs in younger patients in this country, and part of it is the population. We have a younger population, but again, I mean, it is multiple risk factors that gets these patients at a younger age. 46 years old, smoker, referred from a community hospital complaining of epigastric pain, and the ECG, as you can see, it shows massive anterior ST elevation, and also the ST elevation includes the lateral leads up in one in AVL. So this massive anterolateral, we got a chest X-ray on this patient, and as you can see already, there's some pleural effusion on the left side, and there's some congestion there. The RCA is large, dominant, and as you can see, it is free of disease. But then you go to the LAD, and obviously you can see that both the LAD and the diagonal, two big branches, two big vessels, both are occluded, and again, two culprits at the same time. So we wired both vessels. Again, tried to do an aspiration thrombectomy, do balloon first without success, aspiration thrombectomy, sorry, and this was not successful. Multiple attempts of ballooning, and we could not get it open at all, despite injecting optimizing the heparinization and giving him also a GP2/3 inhibitors. No attempt of intracoronary thrombolysis was done on this patient. We said, since there was no success, we kept the patient Tirofiban, IV heparin, and we repeated his coronary angiogram again in 2 days, and again, no luck. The vessels didn't open. As you can see here, the wire extends all the way to the distal LAD, so it's in a true lumen. It's not, this is not like a dissection or something. Microcatheter also was attempted to ensure that the distal true lumen, but nitroglycerin distally was injected, and without any success. So we see occasionally in our practice here, we do a lot of, we get exposure to a lot of STEMI cases, and we do occasionally see such cases where there's two culprits. And I think it's important to recognize them. Sometimes they can be subtle, and you can oversee them. So because we are used to one culprit in STEMI, sometimes if the ECG is suspicious, you need to look at at the coronary anatomy and try to explain that. So multivessel disease is common in STEMI. We do see it. 30-40% of the STEMI patients will have a multivessel disease, and usually we treat the culprit vessel only during the index procedure, and we bring the patient in follow-up or during this in a staged fashion during their hospitalization to fix the rest of the coronaries. But of course, multivessel coronary thrombosis is uncommon, and we don't see it so frequent. The pathophysiology of such entity is not very clear. We know sometimes multiple culprits can happen, but multiple thrombosis usually is not something that we see, as I mentioned. I reviewed the literature. There's case reports, but the largest I saw was a small case series, and they suggested that some of the risk factors that can cause multi-vessel coronary thrombosis is thrombocytosis, essential thrombocytosis, intravenous cocaine use, and diabetes and smoking. And our 2 patients had cigarette smoking. ECG is helpful in identifying such diagnosis. So we look at the ECG regularly when you're doing STEMI cases, because sometimes you can be misled with what you see in the coronaries. So to match what's in the ECG and what is in the anatomy is very important. And usually such patients, they carry a poor prognosis, obviously because a large myocardium is at risk. So this is the cases I have. Thank you again for the invitation, and wish you all the best of luck in this beautiful conference. Thank you.
Okay. All right. Thank you again for inviting me to 4TS meeting for 2022. My name is Shadi Reyes. I am an interventional cardiologist at Wayne State University Theatre of Medical Center. I'm currently serving as the cath lab director and director of the cardiac rehab, as well as interventional cardiology research. I was asked to ask about weaning and escalation of mechanical support, but first we can start with a definition of cardiogenic shock. As you can see, the definition of cardiogenic shock pretty standard. It's consistent of persistent systolic blood pressure less than 90, secondary to cardiac dysfunction with signs of hypoperfusion with lactate more than 2 and cardiac index less than 2 and wedge pressure more than 15. Also physical examination findings like clammy extremity, tachycardic, and lactate more than 4. So again, key consideration in the diagnosis and management of cardiogenic shock is this really cardiogenic shock too? So is it septic shock, or is it something else? And then what is the severity of the shock? Is it purely LV or RV shock? And what are the support options that we have in your site? Is it such inotropic therapy, or is there something else like mechanical support, which is the scope of this talk? So cardiogenic shock approach, this slide is courtesy of Dr. Naveen Kapoor. It's a circulatory problem, and then you support the LV, and eventually your goal is to perfuse the coronaries to decrease the to alleviate the hypotension and improve hypoperfusion in the organs. So this is when the patient coming in shock, for example. So the house is burning, and then the fundamentals of the foundation of the house still there. But when you have a full throw to the core burn of the house, then that's very hard to salvage. So our goal here is to identify this cohort of patients who present early with shock and try to support them with the best means possible, and before they end up with a completely unrecoverable state. Therefore, our job comes early in identification of these things, and we have to have some tools for it. And what are the tools for cardiogenic shock identification beside the EKG, the bedside echo showing the ejection fraction, wall motion abnormality, but also there's high use of wedge pressure as well as Swan-Ganz in identification and calculation of more metrics that help us guide the management of these patients. And indeed, centers who has utilized more Swan-Ganz catheter, this is from a CVAD registry, they have a better survival. Why? Because they have more data, they are identifying the shock early, and therefore they are supporting this cohort of patients quickly as well. There is something also, and we have been practicing for a while, but should change as well, is utilization of inotropic therapy. And you can see here, this is very fundamental slide, is to learn from the experience that if you are pushing more than 2 inotropes or vasopressors to a patient with cardiogenic shock, the outcome is not really good. As long as you are at less than 2, you are good. But if the patient requiring 2 or more, then you have to think outside the box for mechanical support. So why inotropes are harmful to myocardium in a patient presenting with cardiogenic shock? Because they increase oxygen consumption, they increase tachycardia, which increase eventually oxygen consumption. It decrease the diastolic phase, decrease the coronary perfusion, and eventually also increase the LVEDP, which is increased wall tension, which is affecting the perfusion of the coronaries. So this is kind of a vicious circle the heart goes through, but you are adding into it by putting more inotropes into these patients. So what are the guidelines? I think this is very important pause here to talk about what are the guidelines telling us how to practice to manage these patients with cardiogenic shock. In STEMI patient, for example, is the cardiogenic shock class 1 indication is revascularization, and if there's an evidence of shock, level of evidence B is to use mechanical support, but that guideline suggesting balloon pump. Similarly, for STEMI guidelines, is patient with cardiogenic shock class 2, or it's considered class 2B. So because there is lack of evidence for when to use and how to use them, and most of what we are practicing now is based on what we experienced in the last 10 years and in development. But we know that mechanical circulatory support comes in different flavors, different axes, different sheath size, and also different indication based on the right side or left-sided failure. This is very important document coming from Sky about the consensus statement on the classification of cardiogenic shock, and goes in details into from at-risk patients all the way to the extreme. These are the unrecoverable, the completely burnout house. So you have to identify this patient early on before they go into the stage E. Stage A, these are the patient at risk, the patient who come with STEMI, the patient who comes with hypotension, but you still did not use inotropic therapy, and they don't have any signs and symptoms of cardiogenic shock, and they are perfusing fine. Class B is the patient where you start to become hypotensive, but they are not hypoperfusing, meaning they have a good blood pressure is good, but it's supported by inotrope, but there's no lactate, CPO still adequate. The classic is the one that has complete all the metrics that we started with this talk about, the definition of cardiogenic shock, where the cardiac acid more than 2, CPO less than 0.6, and cardiac output index is less than 2, and they are not hypoperfusing, and you are adding more and more inotrope to supporting them, and then they go to stage D, which is deteriorating when they are not responding to these measures, and eventually cardiac arrest, which is stage E. So again, I would like to reiterate, again, this slide is important about adding inotrope is not helping the patient with cardiogenic shock. As long as you identify this as a cardiogenic shock, this is not going to work. And as a matter of fact, you are adding more harm in a way, allow me to say it, to these patients if you do. There's certain metrics that we have learned recently, which is a CPO, as well as which is cardiac power output, which is measured by watts. Anything less than 0.6, you see it there on the first line, in the first row. Anything less than 0.6, it increases mortality as you are adding inotropes. But if you have a good inotrope, 1 or less, and also CPO more than 0.8, your survival is better. Let me start with adding a case now, just to kind of illustrate what we learned so far on a case base. 54 presented with chest pain, blood pressure is soft, tachycardic, clear warm extremities, clear lungs, but he is on low dose of levo. So this patient kind of fits stage B, beginning of cardiogenic shock. Classic ST elevation, angiogram is done showing proximal LAD thrombotic lesion, eventually underwent balloon angioplasty and stenting, and the patient was off levodopa at the end of the case. So this is kind of a classic case where you are stage B, you don't need to do more, and you don't need to escalate. Patient was loaded with anticoagulation, antiplatelet therapy, ejection fraction 30%, and so forth. Now, in terms of A patient presenting with STEMI, and this is a more advanced case. This is a 56-year-old man presented with several days of chest pain, multiple comorbidities, severe CAD. This is during the COVID pandemic that we're still having right now, is with chest pain and shortness of breath. So this is a stage C patient because he's hypotensive. He is already on inotrope. He's tachycardic, cold extremity. He has signs and symptoms of hypoperfusion as well. EKG is again showing the SC elevation, AVR, and insole inferior lead, and indeed, RCA is completely occluded, and the LAD is the culprit with completely thrombosed stent and circ disease as well. So this guy, I mean, again, with hemodynamics evaluation, we did a Swan GANs showing the MAP 62, calculating index 1.4, a CPO 0.38, and as I showed you earlier, less than 0.6 is the cutoff for purely LV shock. Again, the power output, this came from 2004, but we have been implementing it more and more recently, calculated by MAP times cardiac output divided by 451. Eventually, and then the higher the cardiac power output, the better the outcome of these patients, and the lower it is also apparently is worse. So why we need mechanical support in this situation is to recruit more myocardium, to unload the LV, to improve coronary perfusion, and to reduce the LV volumes and stress on the walls, and eventually augment the LV. So unloading, reduce mechanical power, minimize the oxygen consumption, and reduce ventricular remodeling. So this case, for example, because of these findings, we said that we have to go with and do an coronary angiogram mechanical support. But however, he has a severe PAD, and this is an urgent situation where both iliacs are really not functioning well and obstructive, cannot accommodate the 14 French sheath. Therefore, we did a shock wave in this case on the right side, and eventually we see it on the left pre and post, and eventually we were able to deliver the sheath in the right common femoral. And this is just to illustrate how the shock wave does. At 4 atmosphere, you do shock. You do deliver erythrotripsy, you go to 6, and in this case, we did 7 millimeter balloon by 60. You see on the right side, the sheath was doing fine, ampulla is in, wire, thrombectomy, 2B3 inhibitor, balloon, stent, and the patient did well, and eventually stayed in the ICU for a few days, and then came back to the cath lab. We did a weaning study on him, and eventually explanted the balloon pump, the ampulla. Again, I would like to mention one thing is one book I read it with my partner is Anand Prasad. I was privileged to be helping him with this book as well, is about the ampulla, and I was privileged also to be asked to write a chapter on weaning and escalation of mechanical support using ampulla catheters. Again, you can from the literature review, there is nothing much done, and we have been utilizing these parameters, hemodynamic parameters, to guide us to manage these patients in cardiogenic shock. But it's very straightforward. If you are having improving hemodynamics, CPO more than 0.6, cardiac index more than 2, cardiac lactate is less than 2, and you are weaning down on inotropes, this is a weanable patient. But if you have a worsening, apparently all these numbers on the other side, then you have to escalate and transfer the patient to an LVAD or transplant center. Also, we shouldn't forget about right ventricle, and the PAPI calculation should be done as well, which is, you see it in the left lower corner, which is systolic PA pressure divided minus the diastolic PA pressure and divided by the RA pressure, and that will give you the PAPI, which should be 0.4, 0.9 or above. So if you have an RV failure as well, you have to think of escalating this patient to having an RV support. The numbers that we really look for are cardiac index, CPO, and lactate. Patients who have lactate less than 4 or less than 2 and CPO more than 0.6, they're going to do well. And the patients who are mixed, we have to restudy again. Are we having a purely LV function, or is there an RV component? And this is where PAPI comes into the picture. But this is a quick illustration of how we can wean these patients. Usually we start by going on the P value, on the P level, especially in impella case this way, in this case, by one P level for every 2 hours, and then calculate the CPO by doing a mixed venous and calculating cardiac output, which will help you calculate the CPO, and also doing the lactic acid. That will help you kind of guide where this patient is heading at each P level to reach P5. And eventually, if the patient is weanable, then you bring him to the lab, you explant the impella and the sheath as well. But you have to make sure once the patient is weanable, you go back to P9, because this is a risk for clotting. And also make sure you are fully anticoagulating this patient as you're going down on the P level, because your RPMs is lower and high risk for thrombosis. Final case is a patient 76 came with severely calcified lesion. We did thrombotherectomy on it based on the IVUS images. However, the patient developed what no reflow phenomena with thrombosis. So it developed ST elevation and then eventually hypotension, and then that's required thrombectomy, balloon angioplasty. But this patient was class stage B because he is almost requiring mechanical support, but we didn't reach a point requiring more than 2 inotropes. Therefore, but this case was happening de novo on the table, ad hoc during the case, not somebody coming from the emergency room. So again, this is a very good guidelines. I mean, a paper to review at least once and go over the metrics and also the parameters for each stages. And I know there's a new Sky document just coming last weekend talking about the same thing as well. So when to employ mechanical support, if you are using more inotrope more than 2, please consider it. Invasive hemodynamic, if CPO is 7.6, it's time to reconsider. Increase lactate, and then here at the level 2. So again, I came up with a rule of 2 for mechanical support. If you haven't more than inotrope, that is 2 or more. If you cardiac index less than 2 and your lactate more than 2, and you are Sky stage 2 or more, then they have to implement mechanical circulatory support in this situation. With that, I would like to thank you again for having me today to talk about weaning and escalation of mechanical support in patient presenting with cardiogenic shock. I am Shadi Reyes from Detroit Medical Center.
Hi, this is Dr. D.P. Suresh. I'm an interventional cardiologist and executive medical director of the Heart and Vascular Center at St. Elizabeth Healthcare in Edgewood, Kentucky. I'm also the president of the American Heart Association Midwest Board of Directors. On behalf of the AHA, I welcome all of you today to my talk. What I'm going to be talking today is the real world experience in implementing STEMI systems of care in the US Midwest region. A 65-year-old male was going by car and started having severe chest pain while driving, became unconscious and wrecked his car. Immediately, the bystanders saw the car come off the road. They called 911 and started CPR. Law enforcement arrived with an AED in about 3 minutes. Initial EMS EKG showed PEA, and then after the shock, the patient returned to circulation, and then you could see the initial EKG. The initial EKG shows sinus rhythm. There's ST elevation in the anterior precordium, suggesting that this patient probably has currently undergoing an anterior wall MI and had sudden cardiac death outside. His initial blood pressure was 166/90. His heart rate was in the 120s. Patient was transferred to St. Elizabeth, and then the cath lab was notified by means of the Pulsera app. And upon arrival to the ED, patient directly went to the cath lab. You can see here angiography done in the cath lab shows a bluntly occluded LAD, and subsequently after PCI, there is a stent in the LAD, and there's a very good result. The objectives of the talk today is to describe the complexities of STEMI care and the outcomes in the Northern Kentucky region, to discuss the Mission Lifeline System Accelerator 2 demonstration project in Greater Cincinnati and Northern Kentucky, gain a better understanding of the components to implement STEMI systems of care in the UAE, and to review strategies to build regional systems of care and improve timelines of care for STEMIs in the UAE. This slide just shows the systems of care for STEMI is actually an ACC-AHA guideline that all communities should create and maintain a regional system of STEMI care that includes assessment and continuous quality improvement of EMS and hospital-based activities. It is a 1B guideline. This schematic shows how the community, the patient, subsequently the patient calls 911, the ambulance services come, and then subsequently the patient is transferred to the emergency room. And then in the emergency room, the patient directly goes to the cath lab. And then from the cath lab, he gets a good outcome. With these policy makers and payments and various methodologies could come out of these system of care. This is a map of Kentucky, which shows that if you look at the map on top, that is where Cincinnati, Northern Kentucky is. The light pink areas are the areas where there are cath labs and STEMI systems of care. And all the other regions, which are shades of red and dark red, do not have a true system of care in place. So this can be extrapolated to areas in the UAE where we could demonstrate and improve the STEMI systems of care. The STEMI systems of care, time to care goals. This slide shows how when patients come to the hospital, they are non-transfers versus transfers. And you can see the goal is first medical contact to device, system goal of 90 minutes or less, and immediate transfer to a PCI capable hospital for primary PCI is the recommended methodology. So instead of arriving by care to a non-PCI hospital and then being transferred, that would take time. And this slide just clearly shows that in Kentucky, for the non-transfers, how if they were to come to a non-PCI hospital, how the time is higher. It's about 70 minutes, whereas if they come to directly to a hospital where we provide emergency care and angioplasty services, that time is a lot reduced. Next. This slide is a very important slide, and it shows why, if you have a clear STEMI system of care, you literally would save lives. You can see that if there is a system delay, it's directly correlated to mortality. When there is 0 to 60 minutes, a patient reaches the lab and gets treatment, the mortality is 15.4%. Whereas if you look at from 61 to 120 minutes, it jumps to 23%. And finally, from 181 to 360 minutes, it goes up to 30%. So there's a direct mortality benefit for us to do this and providing systems of care. The next slide shows the Kentucky non-transfers and the transfers. A non-transfer is patients that go to a smaller outlying hospital and then get transferred to STEMI care, versus the other one is showing transfers, and transfers directly into a STEMI center is probably the methodology to go with. Next. This is just shows the Kentucky Board of Emergency Medical Services STEMI destination plan on the left, and the Abu Dhabi STEMI protocol that they use. So this kind of care can be done in different places in the world, and we could have clear benefit of mortality when we do STEMI care across different areas in the UAE. Next. Generally, when you look at the treatment of acute MI, this is just a slide that when they go in, they start the patient on oxygen, patients get aspirin, and then if the patient has a high blood pressure and complaining of pain, morphine could be given. And in some patients, if the blood pressure is high, nitroglycerin would be beneficial. Of course, we should be careful with nitroglycerin if they have lower blood pressures, because that could extend the size of the infarction. Most of the time, pre-hospital EKG and pre-hospital notification is absolutely key. In St. Elizabeth Healthcare, where I am from, We have pre-hospital notification. Next. It goes into the Pulsera system. The Pulsera system shows it's a cloud-based platform device. As soon as the patient has the MI, the EMS professionals can load the EKG into the Pulsera. Pulsera is activated throughout our system to our cath lab nurses, cath lab professionals, and the interventional cardiologist. The interventional cardiologist reviews the EKG and automatically activates the cath lab. All of them come to the cath lab, so the patient is able to bypass the emergency room and come directly to the cath lab for activation of the STEMI. Next. If you look at pre-Pulsera, we had a door-to-balloon time of 92 minutes. Post-Pulsera, that dropped to 78 minutes. And later, during further years, in 2018, we were able to get a door-to-balloon or first medical contact to balloon goal of less than 90 minutes. We were able to get it to 59 minutes. Next. So the Mission Lifeline project showed that regionalizing care is very important and has big benefits. It was done throughout North America in various centers in all across the country, in Albany, New York, Cincinnati, Connecticut, Denver, Houston, Las Vegas, in Little Rock, Arkansas, in New York, Portland, Seattle, and in Virginia. What did it show? It showed that identifying strong regional systems of care champions, forming a strong self-sustaining regional mission, having clear diagnostic and treatment protocols, uniform data collection, and prompt and consistent feedback. What did it show? It showed that the EMS first medical contact to PCI within 90 minutes, arrival to a STEMI referring hospital to PCI within 120 minutes, and overall key processes and clinical outcomes. Next. What was powerful in this showed that if you are able to achieve this, that if the patient bypasses the emergency room and directly comes to the cath lab, less than 20 minutes, you could see there's a mortality of 2.2%. Whereas if the patient comes in and is in the ER for greater than 20 minutes, there's a mortality rate of 4.5%. So you can clearly see that by doing something like this, there's a 50% reduction in mortality by bypassing the emergency room and directly going to the cath lab. Next. This is just a schematic of North America showing multiple regional centers of STEMI systems of care. And you can see that there are a lot of areas in North America which still don't have facilities just like other parts of the world. So forming regional systems of care is something that would be very beneficial. In addition to that, this also helps the fire and EMS services and the Independence Fire District. All of them get a goal, and then they get awards from the AHA for gold and gold plus EMS services. These are just recognitions that the EMS and fire departments can do along with hospital systems. Thank you so much for listening. Have a great day. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Umar Rahilak, for the invitation, and congrats on your progress of your meeting. I've recorded this just a few hours before my presentation today on Friday. Most likely I will not be available with you live. So in this few minutes, I will discuss with you the role of the drug-coated balloon in STEMI primary PCI. So a few cases here to state my point of view. First one is a 40-year-old patient with peptic ulcer and no insurance, end up in another facility with no PCI capability, came to us with inferior changes, suggest of right coronary, it could be left circumflex. We do our case of radial with the known cocktail ticagrelor here, loading an aspirin and IV heparin, and the load also with statin. Right coronary is normal. The left circumflex subtotal, you can see here. And here the patient was wired, and we use here JR 3.5 guiding, pre-dilated. We try to heal the lesion, spend at least 2 minutes on and off, 30 seconds, 40 seconds, until I get a good flow with no dissection persistent and no residual, at least less than 20. Then I go with the drug called balloon. This is what I did here, and there are many of them available here. In this case was sequent, please, 2.5 by 30, and we had a good results, and as you can see here, down your right. And the patient was fine, discharged, and follow-up, everything's fine. Another case is a sport teacher while playing and in the gym. He had crashed and ended up in our facility. In this case, patient had a clopidogrel loading with aspirin. I mean, this varies from place to place. Another institution, again, it looks inferior here. And this was a right coronary. You can see plaque rupture, and but the flow is fine. This patient, again, JR 3.5 guiding, wired, spin balloon, I think in this case was 2.75 or I can't remember, or 3 balloon, and by 20 spend, I'm sure like 20 or sorry, 90 seconds until I get the good results. You can see here the first results, you know, was not that good. Then by persistent ballooning, and then once I get a good flow, no residual dissection, and then I applied the drug called balloon here. Again, here was, I think, another sequence, please. But this patient also had the left circumflex and LAD disease. Most likely had a history of high cholesterol, which we didn't know at the start. We discovered later on. Anyway, again, I dealt with this left circumflex, which is chronic, and this was several balloon by 2 by 10, then DCB 2.5 by 15. Again, once there is a good flow, no dissection, and no worsening ECG changes, no pain, then patient, then I finish there, and then patient continue on DCB on dual antiplatelets. The first one I only kept him on aspirin after a month, and this one I still, a patient came back to me after a week. He's fine, but he's not happy with the medication he's on, especially the statins, because very high dose after I saw that. Anyway, this patient need to discuss with them and the benefit to get the right results. The third one, this is very interesting. This patient actually is a director of movies, and they came to me and complaining of having chest pain just half an hour ago. Looking at the ECG, nothing. Then I said, okay, fine. I did the echo as well, it was fine. So, stage 1 stress ECG, he developed this. You can see unsustained VT, and the ECG showed anterior STEMI, and cath lab activated, and you can see LAD is occluded proximally, and of course this one again. A young man was himself was surprised. Said, "Doctor, I don't want metal." I kind of heard this about the problem with the stent. He said, "I've heard about this. I don't want." I said, "No worries, I'll do my best." And that was the results after several ballooning, and then once I get a good result, I said no residual stenosis, good flow, things fine. Then here I apply the drug called balloon. Here was again, I think it was like 3 by 25, and you can see the results is fine. And I saw patient actually just after 3 months, and I've done for him stress ECG is fine, echo, no regional wall motion abnormalities, and I actually simplified his medication to just I think tetraprolol now and statin, and he doesn't like a beta blocker, so I in this case I stopped. The third case is a patient, 32 years old patient, is going for hydrocele surgery. Has been having too much pain from that. And then he came to us with ECG changes suggesting of something happened in his anterior LAD. And you can see here, LAD distally, it's occluded. And this is just continuous film. And you can see there's also a proximal lesion of LAD. So something here, maybe plaque rupture the proximally, and there is something here, and we don't know what's really happening here. Is it bridging or not? We don't know. Right coronary is fine. So this patient, again, we wired his LAD, and we were able to get that amount of plaque out, and lesion was quite, stenosed here, and we have to use aspiration to get that. And then I applied here because I had a kind of good result, but a bit of dissection maybe. Then I said, okay, better to go, because I have no idea what's going on there, and instead of putting a stent and very distal. So this, after multiple pre-dilatation, I applied a long drug-coated balloon, and again spent like 90 seconds here, and that was the results. And then also because of, remember, they had the proximal, very proximal here, I applied another drug-coated balloon here. Is a magic touch. I'm sure all of you heard about that. And so that was the results, and the stop there. And this patient actually came back after 5 weeks with a chest pain, which is atypical, and seen by my colleague, another colleague, and he did angiography diagnostic and also followed with the FFR to make sure what's going on. You can see here, like a bridge we have here. We could have, if we put a stent here, we would not get a good results. So this is after 5 weeks. You see the LAD is nicely open, and proximal, you can see LAD. So, and he did a FFR, and it was beautiful 88. So that was the result. So basically, we're trying to say here that it's a long journey. PUBA, bare metal stent, drug stent itself, first generation, second generation. Then we came with the scaffold, which was not successful. I think we need to go back to idea of keep the arteries off metal as much as we can, and I think we have the answer. And there are some studies already established in the field of the in-stent stenosis with the balloon, and we've seen some small studies about the balloon STEMI, and so 1-to-1 we get the good results. And then this is the benefit of having drug-coated balloon, homogeneous drug eluting, no risk of stent thrombosis, and no risk of shorter DAP duration. So in conclusion, I think there is a hope we can use DCB in STEMIs if it's done in a right way, in a right patient with right reason. Thank you very much.
All right, gentlemen. How stimulating lectures. Very, very nice. Thank you all. Dr. Omar, you are muted, sir. You're muted. We can't hear you. If you don't unmute yourself, okay.
Can you hear me now? Okay. Well, it was really outstanding session, and we learned a lot, and I really appreciate all the presenter. Very interesting cases, very challenging one, and we learn a lot from Dr. Reha and Dr. Abdullah about the drug-eluting balloon as an option for STEMI, because sometimes you like to have that option actually. And we have a lot of other things kind of being presented. All seem to be really, very interesting, and it was really good. I don't know if you have a question from the audience, or if anybody have a question from the panel.
You know I have a question for my good friends, Dr. Kiwan and Dr. Abdullah. And Dr. Al-Zubaydi had to leave, so he escaped. But about the drug-coated balloon, excellent data, of course, in acute MI setting. What do you all propose in the post-COVID realm with increased inflammation, is there any role for drug-coated balloons in this inflammatory state that happens in the coronaries? I'm not talking about acute MI. I'm talking about to prevent this thrombotic milieu that happens. Is there any role for future studies on that for non-occlusive disease? I'm talking about endothelial dysfunction. And that's for anybody. Anybody can take that one.
Abdullah, what do you think?
Assalamu alaikum wa rahmatullahi wa barakatuh. Really, I was not able to. I had to leave because I'm actually outside the room. So thank you very much for the invitation. Great topics. The reason I put forward this topic, Omar, is because maybe it's overuse of the stenting nowadays, and because of we are not getting the results. The imaging is not available all the time. People want to do the stent properly. You have to have the imaging, as some of the guidelines, some of the experts says. Young people having the ST elevation MI nowadays, and they are not adherent to the medications. And we have problem with the DAPT, as you know, with the continuing short, long. There are many reasons for us to think differently. That's why I and the evidence is there to help you. I mean, I know it's small sample, as Dr. Yahya Kiwan nicely reviewed for us, but we need to find another way, not just stenting. And people. The artery is there. Nothing better than keep the artery as native as possible. So that's the whole idea. I mean, the drug-coated balloon in the COVID, I don't know. I mean, I've had patients who coming with unstable angina and chronic syndrome. I treated them with that as well, according to the guidelines. But I don't know where the role of the DCB and the COVID.
Yeah. Do you hear me or no?
Yeah, we do.
Okay. Well, can I have a little comment? Abdullah, thank you very much. Beautiful cases. I presented the theoretical part, but I think supported by a great experience from Abdullah, which thank you for that. I have only very few cases of DCP just before COVID, and with COVID, the number of cases came down. But as I don't have an answer on a patient with COVID, but I think in COVID patient, if you want to make it as simple, as non-complicated, and as short, probably DCB is very good idea. And we don't know the status of the vascular pathology as you presented, Annie, today. Probably if you avoid more inflammation and more trauma, that will be a good idea of avoiding stenting. But in general, if you go all through the trials of comparing balloon angioplasty and thrombolytic therapy, simple balloon angioplasty and bare metal stent and drug-eluting stent, the only difference was target lesion revascularization. There is no benefit of all the trials in a primary angioplasty between balloon and metals, and the only difference is in TLR. No survival benefit, no reinfarction benefit. That's in the trial. So I think I wrote a little chapter in my book about the use of DCP in primary angioplasty. And I think, in the future with the, probably is going to be more and more in use. So that's my opinion. Make it simple and make it short if possible.
That's great. Thank you. Dr. Parviz, do you have any comment on endothelial dysfunction and the use of these kind of anti-inflammatory mechanisms?
Thanks, Annie. Of course, I don't have any data or information in regards to endothelial dysfunction with DCB. One question I have for both these experts, of course, Salam, Dr. Abdullah Shahab and Dr. Kevan. We know that we don't want to put a stent. We are worried about anticoagulation, duration. How do you think about, let's say you've done a STEMI at 2 a.m., you put a DEB drug delivery balloon or drug-coated balloon, and you go home, and how comfortable you are sleeping and not worried about reocclusion, that somebody will call you back. And of course, maybe you have more experience. That how many of reocclusions you have seen in the last few years of your experience?
Yeah, well, thank you very much. If I may answer that, Yahya, if you just this is the at the start, when you have building your experience, I think you need to start with the stable coronary artery disease, where you start your doing the POBA properly. We are not preparing the lesion properly. I mean, if you get the proper, lesion is already, beautifully open, TIMI flow 3, very minimal residual stenosis there. That's in chronic stable, I'm saying. Then, you apply your DCB. Now, this is different slightly in the ST elevation and acute coronary syndrome, because you need to heal that plaque, whatever is there, erosion or rupture. So you need to spend some time. This is the impatient we have with our intervention nowadays. We need to go back with the ideas our experts given us. So this is the beauty of it. I want to comment on one of our expertise today is when used penumbra. I really like this device, because especially with the heavily thrombus, lesion we have nowadays with the COVID, and beautiful, when you get this device there and you have the road open for you, then you're able to decide not to put a stent, just clean the artery and use your, whatever DCB, whatever you like. So this is my input here.
Now, I have a direct answer to you, Yasser. I think I presented in one of my slides, I was in rushing, but in a rush. There was a 250 cases presented in PCR 2018 of using DCB in primary PCI. The reocclusion rate in each group was 1 case only. So I think the fear of going to sleep at 2 a.m., I think it is not there. Once, as Abdullah said, you are really happy. There is no type C dissection. There is TIMI flow, and there is no more than 30% residual stenosis, and you wait like 5-10 minutes in the cath lab. The reocclusion rate is very low.
Yeah, I think that's very encouraging. As you said, in small vessels, we are using it, diabetics, we are using it, and whenever there is all of the concerns, we had a good experience in UK. Sheffield and Norwich, we were using a lot in DCB or drug delivery balloons. Not all the time in STEMI, but this upcoming thing was coming up, and then the data from Milan and Antonio, they were using quite a few. And of course, with your presentation, we will try to embark more in our practice as well. Maybe slightly different in the cultures, because yes, you need to be brave enough to do this at 2 a.m. and then think and relax and sleep well. But great presentation. Thank you.
I think to the panel, I would say wonderful presentations. I do have a question about multi-vessel presentation. Dr. Al-Zubaydi presented so nicely, and he had to leave. So, and my question is always now about inflammation and post-COVID, of course. So are we seeing more of this multi-vessel thrombosis, do you think? And how would we attack that again in this post-COVID era? Anybody? All of you.
Dr. Halak, I think he's muted.
He's muted. You're muted. We can't hear you.
I think it's a acute MI with more than one culprit artery. It's, I mean, we see it once in a while, and what to do with it? Of course, you have to start with the bigger one, and then you go for the smaller one, because if you have more than one completely occluded artery, you have to try to save as the biggest part of the heart as soon as possible. Now, sometimes it's really hard to tell which one is acute, and sometimes we can have acute STEMI with some old occlusion before. It's hard to tell sometimes, and sometimes just putting the wire in there. If it's, I would always go for, if we are in doubt, go for the bigger one first, because time is money, and you want to save as much as possible. And tend to be probably the multiple plaque rupture at the same time, probably more common in younger patients, probably who have some more inflammation in their body, and probably have much more of the liquidy plaques in their arteries, probably they have more likely to have hyperlipidemia or high LDL. I think elderly patients less likely to have those. They have more calcified progressive stenosis gradually. Regardless, I mean, I think if we have somebody with 2 arteries blocked, we'll try to fix the bigger one first.
Is this because of cytokine storm? Do you think that we'll see more of this multivessel thrombosis?
I think it's inflammation. As you know, the theory, nobody knows why people have acute MI, rupture of the plaque, why the plaque ruptured. And of course, the theory, inflammation is very hot theory, that there is inflammation, especially at the edge of the plaque, will make the cap is very vulnerable and it rupture. And so the COVID patient is kind of slightly different than the traditional plaque rupture. There is more of thrombosis, inside to thrombosis, I think, in addition to embolization. They may have some damage to the endothelium, causing the inside to thrombosis. And they have, most of the time, they have normal coronary with the clot, remove the clot, everything back to normal. I think they are a little bit different bird than the normal atherosclerotic patient.
I think we'll be seeing a lot of those birds coming up. So
I think we are running out of time, already 9:45. I mean, it's really beautiful kind of session and really excellent speakers and panelists, and we can keep going and going, but I guess because of the time limit, I really would like to thank all of you. It was really great meeting and a great session, and I hope I hope everybody enjoyed it, and looking forward for the third day tomorrow for another exciting day. Thank you so
Awesome.
much.
Thank you.
Thanks, everyone. Bye.
Thank you. Bye.
Thank you.